of chronic disease and preventing unnecessary hospital utilization. You're at the center of this critical work. And you should also know that MDPCP is the largest Medicare advanced primary care program in the nation, both by the number of practices and on a per capita basis. And know that you are at the center of the advanced primary care movement that you and your colleagues have accelerated here in Maryland. But the program is only as strong as the staff in our primary care practices. Primary care practice staff such as yourself are at the center of changing the delivery system. In fact, the practices in this program serve as a model for the nation. We couldn't do it without you. So what should you expect at today's event? For some background, we've held several previous staff training academies. Last staff training academy was held virtually in 2020. This event covered MDPCP basics and team-based care, among others. Our learning manager, Raghavi Anand, will talk more about what sets apart the staff training academy from others. So at this staff training academy, we have some great speakers from around the country who are lined up to discuss relevant, timely topics with you, from patient engagement strategies to social needs and beyond. We thank you for attending today, and we look forward to hearing more from you about this event, including your takeaways and opportunities for improvement. Most importantly, we hope you will leave here with some new skills and ideas about how to improve primary care for your patients. From MDPCP Management Office, again, thank you.
Okay, what a great welcome. So now just a quick round of introductions from the team running the show here today. My name is Raghavi Anand, and I'm the Quality and Learning Manager at the MDPCP Program Management Office. I'll pass it on to Kelsey.
Hi, everyone. I'm Kelsey Toops, and I am the learning intern with Raghavi at Maryland Primary Care Program, and I'll pass it to Timmy.
Hello, good morning, everyone. Thank you so much for joining us today. My name is Timmy. I am the CEO with GS Staffing, a contractor with MDPCP for this training today. And then I will hand it over.
Good morning, everyone. I'm Kemi Adiola. I'm one of the Chief Operating Officers with GS Staffing.
Excellent. And a big thank you to GS Staffing for helping us to make today possible. I will quickly note that if you have any questions or need assistance throughout the course of the Staff Training Academy, please reach out to one of the four of us and we'll be happy to assist. You can also identify us because we have these specific blue backgrounds. So I have the distinct honor of being present here today to kick off this innovative, timely, and relevant Advanced Primary Care Staff Training Academy. Whether you've attended a Staff Training Academy in the past or this is your first one, we're excited that you're here. What sets this year's Staff Training Academy apart from previous ones are the clinical and non-clinical tracks. You might have noticed that when you registered, you were asked to designate which track of sessions you'll be attending today. This new feature is to provide targeted sessions for primary care practice staff based on your background, training, and role. The topics of today's sessions are relevant and timely. Not only does current literature indicate that these are important topics, but also we heard feedback from several practices and CTOs that these are topics about which they wanted to learn more. And just to make sure everyone has the same background information, the Staff Training Academy is designed for primary care practice staff for the purpose of expanding knowledge, developing tools, and improving areas of expertise with respect to advanced primary care functions, population health management, and patient health outcomes. We hope that based on this information, you'll set some personal goals for yourself for today's event, whether that is expanding your knowledge at one session, learning something new at one of the sessions you'll be attending, or deciding to engage with the presenter during the Q&A session. As the Quality and Learning Manager, a large part of my job is to develop content for and manage the MDPCP learning system. For this year, the MDPCP learning system was revamped to intentionally focus on three core concepts. The first core concept is strategic goal alignment. This means that all learning and development that the PMO offers should align with the program's strategic goals and priorities. The second core concept is that the PMO and MDPCP participants should foster and propagate a culture of all teach, all learn, so we can grow and support one another throughout the healthcare transformation process. The final core concept is support and sustainability. To expand on this, MDPCP offers a variety of free learning resources, including live events, on-demand videos, and technical assistance, but by way of our incredible team of practice transformation coaches. The PMO is here to support and assist with developing sustainable solutions or enhancing existing processes. And this year's Staff Training Academy is a testament to the revamp of the MDPCP learning system. I hope you'll witness the shift and be able to see it here today. Before we move on to the good stuff, I'll just take a minute to cover some housekeeping items. So as a best practice, we ask that you keep your phone and/or microphone muted if you're not talking, and especially during presentations. We want to make sure everyone can hear our speakers clearly and that we minimize any feedback or background noise. We anticipate that many of you will have questions either for the speaker during their session or about the event. We encourage you to submit your questions using the chat feature on the Zoom control panel. For questions about the event, we'll address those in the chat directly. Any questions you may have for the speaker will either be addressed during their presentation or at the end of their presentation. Just a couple etiquette guidelines, just be mindful of background noise if you do unmute to ask a question. And if you would like to unmute and ask a question to the presenter, please do use the raise hand feature, again on the Zoom control panel. There is some CME information on this slide, which we'll cover later as well. If you have any technical difficulty, we have Zoom support information at the bottom. With that, I will turn it over to our keynote speaker. We're thrilled to have Anne Greiner here today from the Primary Care Collaborative. Thank you for being here today, Anne. I'll turn it to you.
I believe Anne was just in and something happened. Give us a second and she'll be here shortly, okay? Thank you for your patience.
Thanks so much, everyone. And as you're waiting, I do encourage you to take that pre-test, which Kelsey has dropped into the chat if you haven't done so already.
And I will redrop that into the chat if you were not here yet whenever that was sent.
Thanks so much, Kelsey. Good morning, Anne. Thanks for being here with us today. We've just completed our welcome message, so we'll go ahead and pass it to you for the keynote.
Good morning. I'm so pleased to be joining you this morning, and I really want to thank Chad for the invitation to address all of you. I'm a huge fan of the work that's going on in Maryland, and I know that I have the opportunity to speak to those who are at the front lines doing that important work. So I'm very excited to be here this morning. I want to make sure we've got some time for questions, so I plan on speaking for about 20 minutes and then really invite you to ask any questions. So please be thinking of them and putting them in the chat as we get underway. Next slide. Today, I'm going to talk about how critical it is to have a high functioning team to deliver high performance primary care. Next slide. First, I'd like to just tell you a little bit about the organization that I lead, the Primary Care Collaborative. We were founded in 2006 because both primary care clinicians and employers were dissatisfied with the kind of primary care they were either purchasing or able to deliver. And they came together around the patient-centered medical home model, which I think many of you are well aware of. Came up with some joint principles. Those got turned into standards. The patient-centered medical home model was really launched. And it's been widely adopted. According to the AMA, about a third of all physicians, we don't have that data for NPs or PAs are in a patient-centered medical home. We've updated those foundational principles, and I'm going to talk about that in a bit in 2017. And we also rebranded from the Patient-Centered Primary Care Collaborative, which was a lot of P's and C's, to the Primary Care Collaborative in 2019. Next slide. So I mentioned our updating of our principles. And so they were first adopted in 2006, 2017. We updated them through a process of involving about 100 different stakeholders. And importantly, where they evolved, I think, is this whole notion of a team. In 2006, there was a focus really on the physician and the patient. And I think we've learned a lot over over the last couple of decades that to provide the care that patients need, a comprehensive set of services, we really need a team, and that a doc just simply can't do everything. So we really have expanded our notion of who is critical for that care. So team-based and collaborative is a new principle. We also added equity, and I think that's a strong link with team-based, because there are many things that patients need, connection to social services, for example, mental health, addressing SUD, that really are going to best be delivered when we have a full-fledged team. So this whole notion of equity was also added. We also know that only about 20% of patient outcomes relates to healthcare. And so it's really important to think about these other services that we might connect to. The other way that these principles evolved is to bring in a much deeper understanding of the notion of patient engagement in your care and family engagement. And I think over the last 10 years, we've really embraced that. Next slide. We are a membership organization. We have 70 different members. They are incredibly diverse, and they include all of the specialties in primary care, the behavioral health specialties, docs, NPs, nurses, but then all of these other organizations. And why do they join an organization like PCC? Because they believe that we need to strengthen this foundation of our health system. So we have consumer organizations like AARP and Families USA and the National Partnership for Women and Families Health Plans, both national and regional, employer groups, pharmaceutical groups, tech firms, and the like. Next slide. Our board is also very diverse. And I mean, I think you could say we practice team-based governance and team-based advocacy. Next slide. And since I took over the PCC in 2017, we've really begun to pivot the organization, not away from the patient-centered medical home, which we believe that and its various variants, if you will, which have continued to evolve, is absolutely where we need to be. You know, a population-based approach to primary care, proactively understanding what your patient population is and proactively meeting their needs, using technology, better access, et cetera. That's all absolutely critical. But what we have found in looking at the literature and speaking to many experts is that the model in most places is underpowered because of insufficient investment in the model and in primary care in general, and also because primary care practices are still paid on a fee-for-service basis. There's also the other problem that we don't have an alignment of incentives across the entire medical neighborhood, a larger problem to tackle. Next slide. So this really has informed our strategic imperatives, and we're focused as an organization on broadening recognition for primary care as central and foundational to high value care, but also what we focus on in terms of our policy work, and it very much relates to team-based care, is reforming payment and the delivery system in order to achieve those shared principles that I shared with you earlier. In addition, our board has asked us that in everything we do, we bring an equity lens. Next slide. So I mentioned that I took over in 2017, and in our early days, we really focused on how do we support states to help them pivot their health systems to primary care. More recently, we've been very focused on a federal agenda, and that has been informed by the National Academy of Science, Engineering, and Medicine report, which came out in May of 2021. That report very much emphasizes team-based care. There's an entire chapter on it as essential to the delivery of high-performance care. If you haven't had a chance to read it, I'd at least take a look at the executive summaries, which are all available on the NASM website. Next slide. So, team-based and collaborative. I wanted to unpack for a moment one of those 7 principles. This is our definition of what that means. Interdisciplinary teams, and that can mean those that are clinicians and non-clinicians. I know for some in medicine, I know I've had this experience where docs are thinking about that as we're working with other specialties. What I really am conveying here is it's across both clinical and non-clinical, and the patient's part of that team and their family working collaboratively towards a common goal. They are focused on coordinating and integrating the services that they provide. All members of the team are working at the top of their skill set according to clearly defined roles and responsibilities, and that's actually part of the hard part. And they're also trained in leadership skills, so they know how to partner with each other and how to work with patients and families to meet priorities and goals. Next slide. So I also wanted to reflect for a moment on what is driving this movement towards team-based care. And I think there's both supply and demand factors for why there is this movement towards team-based care. I think it will not be a surprise to you that we have a primary care shortage. The number of physicians going into primary care continues to decline. We do have a rising number of particularly NPs and some PAs going into primary care, but they too are more likely to choose specialty care over primary care. So overall, we've got both a shortage and a maldistribution. So the notion of expanding the team to provide care is that we're bringing more folks in to try to meet the demand for primary care because we have a shorter supply. We also, I think, are seeing different strategies with respect to how to staff, particularly in some of these, in some new corporate arrangements, a lot more use of teams. On the demand side, as I mentioned earlier, we have an appreciation for a much more complex set of needs that patients have that are best met through team-based care. So an aging population with increased care complexity, more social vulnerabilities. And we have a growing evidence base for how bringing in behavioral health, addressing, dietary needs, many other aspects of care that are, not strictly within the purvey of what you think of as traditional physician primary care, whole growing evidence base for them, and then the need for a broader team to address these patient needs, which are evidence-based. Next slide. I wanted to include some of the existing evidence base for team-based care, and I think we see it with outcomes related to quality and utilization and cost, even evidence that we have lower burnout if we do practice in teams, as opposed to all responsibility being on, and full-fledged teams, not teamlets of a doc and an MA. Lower burnout because you have more personnel meeting the needs of patients, less emphasis just on one or two individuals. And also very good evidence from the VA and their PACT model. That's the last citation. Next slide. But there really is no one model. And I'm not sure why my slides look a little wiggy. Sorry about that. They kind of morphed. There really is no one model of team-based care. I am often asked, what is the ideal team? Who do you need on that team? How much does it cost to set up team-based care? It really needs to be dependent on the needs of the patient population that you're serving, and also realistically who you have in your geographic and virtual community to draw upon. So I think, we see different models. If we're talking about a primary care practice that is contracting with an MA plan, a Medicare Advantage plan, they may be really focused on care coordination and navigation and social support and connecting to community-based services, and complex care. A pediatric and adolescent model may be more focused on integrating behavioral health. A commercial population might stress wellness care and comprehensive medication management, and that will have implications for who's on your team. Next slide. But I think there are a lot of commonalities about well-functioning teams. And when I thought about, a team in terms of the popular culture that I think really embodies a lot of what we want to see, in our primary care teams, I thought of Ted Lasso, who I think, if you're a Ted Lasso fan, raise your hand out there, who I think really instills a lot of respect for every person on that team and their expertise, is a really good communicator. I'm not sure Ted uses data and technology, but that's absolutely critical, to have good benchmarking data and to have the ability to be communicating across the team. That's going to be essential to a high-performing team. I think you also need a shared mental model. What is the approach to addressing patient goals? What are the values of the practice? Accountability is going to be absolutely essential. Yes, that is very important. It does not mean that the accountability in the legal sense means that individual, usually, a doc, sometimes a nurse or a PA, is always the leader of the team. Leadership can shift depending upon the situation and also who the patient prefers. So that's also, a concept that I think takes a while to embrace and to understand how to practice under that construct. There are 2 stars on this slide, because I think one of the 2 of the more challenging things in building really high performing teams is defining the roles and responsibilities of each of those members. So you have clarity. Yes, there may be overlap, but you really need to understand the roles and responsibilities. And teams are not effective unless they are adequately resourced. So those are really important attributes of a high performing team. Next slide. And we need many policy changes to support teams. And I'd put on the top of the list paying primary care more and differently. And I'm going to drill into that quite a bit, because as I said earlier, that's what we as an organization work on. I mentioned earlier that in order to have good communication, you need data and technology. In order to understand how you're doing relative to your patient population, you need good performance data. You need to be able to have dashboards and understand how the team is performing. We also really need reform in undergraduate and graduate education. This is beginning to happen, but we need much more of it to increase exposure of the different clinical groups when they are in their undergraduate and then when they go into their residency. It used to be, and I think it still is in many situations, where you just don't have an appreciation for the training and education skills and competencies of members of your team because you've had no exposure. Finally, I think we also need to have structured ways to bring the patient perspective into the care team. So now I'm going to talk a lot more about paying primary care more and differently to really support teams. Next slide. Next slide. So I think there probably would be no argument that we have underinvested in primary care. And maybe not all of you are convinced that we need to move off of the fee-for-service chassis. But as an organization, we have adopted that. And the National Academy of Science, Engineering, and Medicine has as well. And I see the whole primary care community moving in that direction. And so we're working to change how we pay and how much we pay primary care to realize that idealized primary care that was articulated in those shared principles. And the way we're going about doing that is building a diverse and inclusive coalition that can advocate for primary care. Given where primary care stands in both the market and the political ecosystem, I think we've come to the conclusion that we need others in the ecosystem to join with us to effectuate bold changes. So we need the insurance companies to work with us. We need the employers to work with us. We need the big consumer groups to work with us to effect these bold changes. We believe that there's a real urgency to enact payment reform and invest more in primary care. We see the primary care infrastructure crumbling around the country. And there's increasingly, news reports of this and data that demonstrates, that we really have a growing inability for people to find and maintain a primary care relationship. We believe that putting scalable models in place that change how we pay will help drive some of the change we need. And along the way, we need good accountability and good mechanisms for feedback and good performance measurement. Next slide. I apologize. I'm so sorry that we had that little outage. Next slide, please. Very focused on changing this payment model and also investment. I think many in this audience may know, but I would say 5 years ago, this was not commonly known, how much we underinvest in primary care. And I actually have a polling question for all of you, because we have put out reports at the statewide basis to look at primary care investment across all payer type, and then to do a drill into the commercial sector. And if you could put the polling question up, I'd appreciate it. So Maryland's primary care spend, above or below the national average? Just if everyone could quickly answer that question. Okay, do we have an answer? It's getting calculated.
Looks like folks are still voting.
Okay, thanks.
Mhm.
This is a chart that always makes me a little nuts, and actually, because every day I hear about more ideas for what primary care can be doing to address various health needs, and I always point to look what we're paying primary care as a percentage of total cost of care. Okay, well. The belows have taken it, but let's see. Next slide, please. 58% to 42. You know, you're both right. Trick question. So when we did this in 2019, the data we had available to us was the MEPS data in just 29 states, and what we found is that Maryland, in a narrow definition of primary care that was just about physicians providing primary care, basically, was just right, very close to the national average. And when you looked more broadly to include NPs, PAs, behavioral health folks, Maryland was actually behind the national average. And in terms of commercial, your rates are actually higher than the national average. So it's actually, you know, a more complicated picture. And it depends on how you measure, and it also depends upon what payer you're looking at. But we have found that this data is very helpful to state leaders as they try to assess how are we doing in supporting primary care in our state. Next slide. And how might we go about changing expenditures to better support primary care? So we have been a backbone organization for many who are working to reorient their systems to primary care. There are 21 states that are now reporting on primary care expenditures, and Maryland has joined the list last year, passing legislation. We look forward to the Maryland reports. It's a very important exercise. It's generally all payer except for the self-insured. The comparators are health plan expenditures, and then states, many of them, and we very much encourage this, then use that data to compel the health plans to increase expenditures in primary care. 6 states have gone down that road. So this is really a way to evaluate, do your expenditures affect your priorities as a state? Oh, goodness, we're spending so little on keeping our population healthy. We need to spend more. So and oftentimes even the legislation calls out, and we want to see integration of behavioral health. We want primary care to better address women's health. We want primary care to connect to community-based services. Again, that team-based approach, but you can't do that unless you properly resource the teams. Next slide. So I mentioned that we are also have taken this campaign, which we have now named Better Health Now, for paying primary care more and differently to the national level. And we launched this in March of last year. Next slide. We have a whole set of recommendations that are very much in line with the National Academy of Science, Engineering, and Medicine recommendations. 50 organizations have signed on to that and are working actively with us on this campaign. Next slide. And basically the recommendations in a nutshell, the elevator speech, are invest in what works, because all the evidence shows that if you invest in primary care, you're going to improve population health, you're going to reduce inequities, and yes, even you will bend the cost curve. It is the only part of the healthcare system where investment achieves these kinds of outcomes. So we need to do more of it. We also want to pay for what we want, not, rescue care, but better health. And we understand that we need to reduce economic and social barriers to get to better health. Next slide. And I'm nearly done, so I'm eager for your questions. We have 3 policy platforms within the campaign. One is focused on integrating behavioral health into primary care. We have seen the administration take some important steps to do that. I'd say beginning steps, baby steps. We need a lot more. We're also working to influence the Hill. They have a bipartisan Safer Communities Act that will help integrate behavioral health into primary care. There's also, our next plank is focused on Medicare, and we are pleased that we are deep in discussions with CMS and the Centers for Medicare and Medicaid Innovation to introduce a hybrid payment within the Medicare ACO program. So we want to see primary care paid differently and more within that program, which serves 11 million beneficiaries. And our last campaign is focused on Medicaid because we understand we need to reduce inequities. And we are very pleased to see the recent Medicaid rules come out related to access and eligibility. We are responding to those right now, and we are coming up with our own set of policies to be announced later this year to strengthen primary care within Medicaid. Next slide. Okay, I guess now I'm anxious to hear from you and any questions you may have.
And just to reiterate here, feel free to raise your hand. We can call on you, or you can drop your question into the chat.
I would be very interested in hearing from you about any work that you're doing on team-based care and where you see it working or what kinds of challenges you're facing.
It seems, excuse me, it seems we have a question. Jennifer says, is there a shift in providers going into specialty care for financial reasons, or why is there a shift?
Well, I think we have a decline in physicians selecting primary care as a specialty. Over the last 10 years, there's been a 14% decline. So it's pretty substantial. It does seem that there are many reasons for that. I think one of them is the pay disparity between primary care physician salaries and specialty salaries. I think the other is just that there's a lot of requirements for administrative work that primary care needs to do. 2 hours of paperwork for every 1 hour of care provision. One study shows that's pretty daunting. So we believe that we need to change the conditions under which primary care works to make it a much more attractive specialty, and that will include helping to increase salaries, but also a work environment where people can feel like they can really address patient needs because they have the resources to do it, and they're not on this hamster wheel that fee-for-service really seems to promote.
Thank you. I saw a hand go up earlier. Emily, I'm not sure if you have a question, and there is another question from Antonia, but I wanted to ask Emily if she had a question for us. We can take your question now, Antonia.
Okay, sorry. It wasn't really a question. I'm coming from Tidal Health. We do implement team care and a few provider that you're implementing it with. Some providers work well, it allows them to spend more time with their patient. So then it gives MA more room to fill routine medicines and call patients about things. But in other places, providers aren't really interested because of just the way that they see primary care for them. They want to know their patients. They want to be more in tune with them, or maybe it's just some are a bit more old fashioned and they feel like these are things that they should handle. So it's definitely tit for tat, but I definitely think that there could be benefits all around to patient care if we implement team care in a lot more facilities, but we might have to really show the differences between like the levels of care. Like, I don't think a lot of patients understand the point of a primary care. So I feel like we should start there.
You said a lot, Antonio, and I think it is true that, you know, if you've been trained in a certain model, that you are fully responsible for the patient in all aspects of care. It is hard to make that transition to a team and sharing those responsibilities. However, you know, I would ask those providers if they feel like they can truly and adequately meet all those patient needs. It's very hard. Quite frankly, it's impossible to do. Now, I think the conundrum that practices often find themselves in is they can't meet all those needs, but they don't have the resources to build out a team. And so that's a very frustrating place to be. And, you know, I think that can contribute to a lot of burnout and a lot of dissatisfaction. So, you know, we really, truly need, I mean, I think, you know, this is a very urgent national issue. We really need to change. We really need to invest a lot more in this, you know, foundation of our health system in order to be able to provide the needs that patients, that really to address patient needs. I would leave you with this because I know we're almost out of time, and happy to stay if that's allowable to answer more questions. But we were 4 years behind the Europeans in life expectancy before COVID. Now we're 6. That is completely unacceptable for a nation of our economic stature, to be doing such a poor job with keeping people healthy. And we know that primary care is the answer. We just need to resource it properly. Are there time for more questions, or do we need to wrap? Asking my meeting organizers.
Thanks, Anne. Yeah, I think we'll go ahead and pause here so our participants can get a little break before the next set of sessions. But thank you so much for your amazing keynote, and it was very informative. We will be sure to send any questions that folks have sent over that we weren't able to answer to you directly if you'd like to answer those via email.
Sure, be happy to do that. Thanks so much for the opportunity to join you today, and fantastic work there in Maryland. Keep it up, and look forward to hearing about your progress as the years unfold.
Thanks so much, Anne.
Let me know if All right, we're good. We got recording. So let me know if you have any questions along the way, and hopefully we'll have some time toward the end. But also, as with Anne, I am happy to follow up with you via email or quick virtual contact if you have other questions. All right. So our learning objectives today are to characterize what patient engagement means to you. I'm sure that everyone on this virtual session, you've got ideas about what patient engagement means to you already, but I'd like to sort of see if we can stretch that a little bit and have a little bit of dialogue about a little bit more broadly what that means in primary care. I mean, I think you heard in the keynote that there are a lot of things to consider. And we're going to talk a little bit about some of the challenges we face in primary care, especially around that time issue, which patient engagement takes time. So we want to just talk a little bit more about that and think creatively about how we can move this along to be more engaged with our patients, their caregivers, their families, and really their communities. We also want to talk a little bit about some strategies for improving patient engagement. There are a lot of resources out there, and I have given you some on the Google Sheet that you have access to, but definitely want to talk about a few of them and also hear from you what you're doing already, because sharing with each other is a huge part of primary care. And then we're going to briefly touch on some technology. I wanted to talk a little bit about how health literacy and technology have an intersectionality that's really important to consider, especially when we're considering issues of health equity and population health. So there's actually a new government health IT playbook that's a pretty dynamic document that's being updated regularly that has some great information, and I have that resource for you. But I do want to talk a little bit more about some of the things we should consider around technology and patient engagement, because we do run the risk of marginalizing certain groups of individuals if we focus very heavily on certain types of technology. I don't have any disclosures. I did sprinkle in a few pictures from my clinical practice and some of my medical students that I thought would keep you engaged. And I do have waivers for all of the photos that I've shared. Timmy, it looks like we have a hand raised. Angela? Was that just an accidental hand raise?
Yes, that was. I'm sorry.
No worries. I just want to, I'm trying to pay attention too, so make sure it's interactive. All right. So hopefully you've used Poll Everywhere before. I try to make this as easy as possible, but I'd like to just pause for just a moment and to get your role or your area of professional training. I do recognize this is the non-clinical track, but I would like to kind of get a sense for who's in the audience. You can either copy that the web link that's at the very top, and that should give you this poll, or you can text. If you text my name 502 to 22333. So either one of those should get you some easy access to just throw in whatever you want me and the rest of the group here assembled to know about your role or your professional training. Might help just also frame some of the comments that I make a little bit later. Or the other option is, if it's just easier for you, you can throw it in the chat to me. I'm not sure if it's disabled for you, but if it's not disabled for you, then feel free to do that too.
I can't see the poll. Has it been shared on the screen?
You should be able to see a chat function, not the poll, but the chat. So you can send the chat to everyone so we can see, everyone can see the questions, and she can also see the questions.
Yeah, so the poll's on the screen. Can you see the poll on the screen? It's different than when Anne used a Zoom poll. I'm using a Poll Everywhere poll because with a larger group, sometimes it's easier to type the longer answers in. So it's not going to pop up on your screen. You're actually going to have to either text in the answer or use that web address. I'll just give it a second, and if we don't get any answers, we'll just keep on going.
Heidi, could you repeat the text number?
Yeah, sure. Can you see it on the screen or no? It's at the very top. It should be 22333. And then you type in my name, which is HEIDIGULLETT 502. And I didn't choose that. It's just what it assigned me.
It's not showing on the screen, so we can't
Okay.
see it. Yes. Do you want to tell me what it is again so I can send it to everyone?
Yeah, I'll just I'll type it in the chat to you.
Okay, thank
but
you.
I'm going to move on to the rest of the slides, but I'll type in
Okay.
the chat in the meantime.
Sounds
All
good.
right. And then, so I just want to talk very briefly. This is not about me, but I do think context is really important. So this work is really important to me, partly because I grew up here in Youngstown, Ohio, which is Northeast Ohio. And it is an area much like some areas of Maryland and Pennsylvania, a number of the steel industry here across the Eastern Mideast or Midwest that really has been ravaged by a loss of industry. And so one of the challenges is that really in the social determinants of health, which you're going to hear about later. So I'm just going to briefly talk about those in the context of patient engagement. I've really recognized that as I've returned to clinical practice in my hometown in Northeast Ohio, the challenges of engaging folks are really contextualized, like really need to understand the stresses and the tyranny of the moment in which people are living so that I can better understand how to engage with them as a clinician, but also how our entire team from the very front to the back of our clinical practice can engage with patients in a more meaningful way. So this is really personal to me. And what you see here are pictures of Youngstown in the heyday at the bottom, and then pictures of what it looks like now. And I am getting also some information from Timmy in the chat. So we have clinical transformation lead, quality assurance manager, practice manager. So all that information is awesome. Director of population health. So I love all your titles and would love to work with you more than just in one little session today. The other thing is, just from my clinical practice, I wanted to share, and you heard a little bit about payers in the earlier keynote session. So I have been both on the clinician side as well as on the payer side and working for a Medicaid managed care company. And so I do really understand the complexities of trying to understand population health from a payer side, but also from a clinician and a community health center side. Most of my 19 years in clinical practice has been in federally qualified community health centers, either in a rural health center, as you see in the center of the page, that's in Eastern Tennessee, or here in Cleveland. All right, so Timmy, do you see on the screen right now, do you see my poll?
I see your question, yes. In 1 to 2 words, what does patient engagement mean to you right now?
Okay, perfect. So if you saw in the chat, you saw the 22333 and then my name and the number. You should be able now to just type in your answer on the text to this particular question. And to me, I'm also putting in the web address in case anyone wants to use their browser instead of their texting. I just sent that to you as well.
Thank you. And also, can I please say something here too?
Yes,
I'm getting a lot
absolutely.
of direct messaging. I would like for Dr. Heidi to see your messages. So if you could please send them to where everyone can see it. Thank you.
Timmy, I think that maybe we might not have access to do that because I can only direct message you or Kelsey. Those are the only 2 people I have access to. So I'm wondering if the rest of the group might have that same problem.
I see. Okay, that's fine. Then I can always, I would send you their answers then.
Okay, perfect. I'm trying to monitor that too. So I'll just
okay.
Consultant, program manager, primary care transformation.
Yes, I'll continue to send them. That's fine.
Okay, cool. Thank you. Ambulatory manager, HEDIS coordinator. So I think everyone can see those now too. So that's awesome. All right, so patient engagement, what does it mean to you? So we have informed decision-making. Excellent. And I'm sure that everyone in their own mind has some ideas about what that means to you. I'll just give it one more second. I know Timmy sent out the web link as well. All right. So I think one of the things, outreach, excellent. I think one of the things we're seeing in this particular question is that this is about patients becoming more engaged in their healthcare, right? The next one was patient involvement. Absolutely. So patient engagement, clearly intuitive, right? Like engaging a patient. But I think when you break it down, it means a lot of different things. And actually, in preparation for this talk today, I did a pretty extensive literature search, and other people as well had some questions about, like, what exactly does patient engagement mean? And I think I'm also a public health physician, and one of the other analogous terms that we use is community engagement. And many of you may use that in your clinical practices too. And that's similar, right? Patient engagement, community engagement. What exactly do we mean by that? So the hope today is that we get you thinking even more deeply about where you are right now. Obviously, you're all primary care folks, so we know that patient engagement matters to you, but kind of getting an understanding of that is really, really critical. I think I love some of these other answers: being respectful, educating the patient on their options and following up on their decision, health literacy, support. Absolutely. All right, well, we'll just continue on. You can still put answers in, because at the end, I'm going to pull all these polls and send them to Timmy and her team, and they'll include those as well in the final version of all of the information for the virtual training today. So really quickly, I also wanted to talk a little bit about the whole person and whole person health. And this is a more recent kind of way of describing what we do in primary care, but very familiar to us, I think. It's really looking quite holistically at how we provide care in a healthcare setting, but also in the community. So right now, I think today in patient engagement, this session was really geared around the individual, but it's so important to think about that individual in their own holistic sense, and then that person nested within multiple layers of context in the family, community, the population in which they live, or populations. And this is also the area where we start getting some notions of what we call intersectionality, where we think about those contexts and layers of context and where they come together. And those are really critical elements for understanding how to engage people, because we know that there are lots of different components that come with each of these identities, each of these understandings, each of these layers of context. And so to effectively reach someone, there's got to be trust and trustworthiness on the part of the healthcare team. And that team, part of that trust and trustworthiness is understanding those different layers of context. There's also an important, and again, I know there are other sessions on social determinants, so I'm not going to spend a ton of time, but I really couldn't talk about patient engagement without thinking about all these other layers of context. So that whole health diagram that I just showed you was simplistic, but nestled within that are all these other pieces, right? And so, like, for example, you heard me talk today about Cleveland and how we're blanketed in all this wildfire smoke today. Well, that's this natural environment, right? The air, the water, the land. If someone tried to talk to me today about how to, improve my diet and how to exercise, I'd be like, listen, I can barely breathe when I'm outside today. Let's talk about this another day. That's just a very basic example of how patient engagement has to be contextualized. The other thing is that a lot of times in clinical care, and particularly in primary care, we're very much focused on the downstream here, right? We're learning how to partner with patients to manage chronic disease. We're learning how to, provide preventive interventions. But we're really also, especially in primary care, learning how to address the social needs, those more midstream issues, right? I can't really talk to somebody about eating healthy if food insecurity is at the forefront of their mind. So I've really got to be thinking about how to effectively engage that person in that particular conversation when I'm thinking about the other things going on in their lives. But none of that is independent of these other bigger picture upstream issues. And we certainly can't solve them in the course of a short clinical visit, but we've got to consider them. So really trying to figure out, where do we engage folks, and how do we make sure that all of these issues, upstream, midstream, downstream, all these layers of context are at the forefront of our own mind. The other thing is, I love this slide. You may have seen this exact slide or other versions of it, but basically it's understanding that if I am engaging with someone and I'm giving them the best known evidence-based guidance for whatever particular issue we're discussing, I can only provide that guidance if it's considered within the context in which they live, right? So if I'm giving this fish guidance about how to be the healthiest fish possible, but this fish is living in polluted water and is not able to actually get what they need out of that water, get the food that they need, et cetera, it's really not effectively engaging that person. So this is just yet another metaphor to think about when you're engaging that individual patient. The other thing is that a lot of times when we think about patient engagement, and you guys are already thinking about this much more broadly, but sometimes we think about it with regard to like counseling and interventions that are around health behavior. And that's definitely a part of patient education. Patient engagement, but it's so much more than that, right? Because we can recommend all these things that are even lower on this pyramid, the factors affecting health that comes from the CDC. But if I'm not effectively engaging that person, then I may not actually be having any sort of impact around some of these higher level interventions, like talking to somebody about preventive interventions like colon cancer screening, cervical cancer screening, smoking cessation, those things that have a really potentially big impact on them and also those people around them. But if the engagement isn't effective, clearly it's really not going to be something that they decide they want to do. The other important concept for us to just make sure is a part of this discussion of health and patient engagement is the notion of health equity and health equality. So I actually have more than a 2-hour session that I do with our medical students on this topic. So I'm giving you the highly abbreviated version, and I hope I do it justice because it is a critically important topic. But the notion of equity is really that we are meeting people where they are with what they need at the right moment in time. So it's not a matter of ensuring that everyone gets the same thing. And as you can see in this infographic from Robert Wood Johnson Foundation, the idea here is that obviously if you provided the exact same bike to everyone, that's equality. Everyone got the same thing, but it's not meeting their needs where they are at that moment in time. And so when we think about patient engagement, I always try to ensure that I have an equity lens around whatever patient engagement we're doing, whether it be on the individual level or it be something that our community health center or our public health department is engaging in. Because it's really important that that notion of everyone has an opportunity to reach their full potential by us providing the right tailored intervention is absolutely critical. So what exactly is patient engagement? So I asked you earlier and I got some awesome answers, and you can see even some more have come in on the chat that Timmy is sending to everyone. But I did pull a couple of the bigger public health organizations we have in the world. So the World Health Organization, and here in the United States, the Centers for Disease Control and Prevention, or the CDC. Their definitions are pretty similar. I wanted to at least provide you with some formal definitions as we walk through this. The process of building the capacity of patients to actively participate in their own health and healthcare. The World Health Organization, as we heard Anne really highlight in the keynote, is primary care is essential. That first point of contact engagement, priority alignment, mutual accountability and transparency are also other things that can come out of patient engagement. The CDC talks about the impact of patient engagement, that people tend to, if they have a higher level of activation, have better individual health outcomes. And on a future slide, you're going to see kind of what that looks like at the population level. And CDC defines patient activation. They sort of use that synonymously with patient engagement as, patients having knowledge and skills, and then also confidence to be actively engaged in their healthcare, much like many of the things you all put in the chat. But I also included some information from a systematic review that talked about that. What is that definition of patient engagement that we should really be using as our unified vocabulary here? What exactly is that? They looked at literature from many, many different sectors and lots of different types of studies and decided that this was their summary definition. Patient engagement is both a process and behavior, and is shaped by the relationship between the patient and provider and the environment in which healthcare delivery takes place. And so I think for me, the really key piece is it's not just the clinician or the provider, but the care team. That is absolutely essential. And the environment in which the healthcare delivery takes place. So that environment has, again, multiple layers of context. We often think about the patient and their immediate context and the clinical situation, and our immediate context is the care team. But also, I think it's important to think about these broader levels of context. In preparation for today, I also found, I can't even tell you, dozens of organizational definitions of patient engagement. Many of them were somewhat similar to what you see here on the screen. But I want to challenge you to think about, what is your organization's definition of patient engagement? Do you have one? Do you and the others on your care team, the clinicians, the clinical team, and the non-clinical team, do you have a shared understanding of patient engagement? Do you have a shared understanding of whose responsibility patient engagement is? I can say honestly that I have not often had these conversations with my colleagues in both the clinical and non-clinical sides of our work. That's a problem in my experience. Perfect time to create one among your colleagues, both clinical and non-clinical. But if you do, how does it align or not align with your organizational values, your mission, and your vision? This becomes really important because patient engagement takes time and resources. And if patient engagement is not aligned with the organizational mission, vision, and values, then it tends to sort of go to the side. It's like maybe a solidifies it as a way you do business, which is really critical when you think about the patients that you see and helping them reach their full potential. The other thing is that patient engagement, and I saw this certainly in the answers that you gave in the chat and on the poll, but patient engagement needs to occur on multiple levels. So I'm talking a lot today about direct care, that level of the individual, but patient engagement also needs to happen at organizational design, organizational governance. One example of this is that, I mentioned I've worked in community health centers for almost 2 decades. Our federally qualified community health centers, 51% of the people on our board of directors are what we call consumer users or patients. So it's important that those people be representative of the populations that we are partnering with in care. And so those folks need to be part of the design. It's nothing about me without me. There's engagements at all levels. But again, that takes shared power. You've got to make time for that. And there has to be a commitment to that at all levels of the organization. The other thing is on policymaking. Sometimes that's little p policy, right? Like it's the stuff about checking in at the front desk. What's the policy around how we engage with folks? Sometimes it's big P policy. How do we spend these grant dollars? How do we know how we're going to actually take on this X, Y, or Z issue with, for example, infant mortality in our particular population in our neighborhood? The other thing I wanted to make sure we covered is the benefits of patient engagement. Now, I could have probably put on here 5, 6, 7 slides, as many of these concepts were broken down in a very granular way in the literature. But I summarized some of them to be bigger buckets, things that are probably very familiar to you in the kind of roles that you identified earlier in this session. So we know that patient engagement, as we defined earlier, right, working with the individual to have them become engaged in their care, really that direct level, individual level. This is not talking necessarily about organizational or governance or policy, but we know that those provide improved individual and population health outcomes, improved quality parameters, and we know that both of those first 2 things have potential to improve financial performance for healthcare organizations, reduce costs for payers. So a lot of times I think we shy away from some of those economic conversations, but the reality is that in the United States, the healthcare system is driven by finance. And we've had a lot of redesign of the healthcare system since I've entered medicine 2 decades ago. And a lot of that is really rethinking how we pay for healthcare. We certainly don't have it right, as you heard Anne talk about, right? We need to figure out how we incentivize and pay for primary care in a better way. But we do know there are a lot of ways out there testing and trying to see how we do that. And we know patient engagement really improves those. We also know that patient experience measures improve. Now, whether or not you're in agreement with whatever patient experience protocols you use in your clinical practice, we know that this means satisfaction. We know that this means retention. This means a lot of ways of continuing to engage over the long term. If I was giving this talk to a specialty group, it would be a very different talk, right? Because those aren't necessarily, maybe some specialty groups, depending on the condition. But in primary care, we pride ourselves on relationship, longitudinality. So the patient experience measures we care about in primary care are very consistent with those longer term engagement options. And then the other thing is that we know that many different groups benefit, and it's not necessarily a bad thing for us to think about how do payers benefit, because they may be more engaged in helping us with pilots and other options. Maybe your practice is one of those that works with payers in your state in Maryland to help, or with the health department to try to engage folks to provide better incentives for primary care. All right, so we'll try this one more time. And if this poll doesn't work, we'll forget the rest of the polls. But again, you can keep Timmy busy here as well if needed. So the question is, how do you currently engage your patients? So I'm just kind of curious what you're using right now. We'll just give this one moment, and if it doesn't work, we'll move on and finish the rest of our talk and then open for questions. So how do you currently engage your patients? And we don't is also a reasonable answer. All right, so I've got portal. So I'm assuming that's an electronic health record portal, which we're all using electronic health records. Great, portal again, social media, electronic health record, phone calls, awesome. Labor intensive, isn't it? The phone calls. Great, another EHR. We use Athena, so we're able to blast out emails, phone calls, and text messages. Excellent, so that really helps with the sort of economies of scale thing, right? So you've got X number of patients on panel for this clinician or for this practice location, and you can blast out all at one time. You do postal mail outs, excellent. So a lot of this is outreach, right? And that's awesome. The phone calls maybe is more sort of in the moment back and forth, but a lot of this is asynchronous, meaning it's not happening simultaneously. Like there isn't flow of information from the patient and the care team happening back and forth. A lot of this is from the care team or the clinical practice outward. Newsletter is another one. Excellent. All right, so those are great. So these are all really great. But I want to talk a little bit more about how we move along that asynchronous communication is fine, but how do we move along engaging patients so that we actually are able to get their feedback in either real time or if it's asynchronous, frequent time that's not separated over a long period of time so that we can actually implement their feedback, whether it be about them individually or about the actual practice itself. So these are some of the strategies that have been proposed in the literature to improve patient engagement. And again, I compiled some resources for you if you wish to dive a little deeper. There's no one specific playbook. Many of this might seem very simplistic, even looking at number one there. But the reality is you have to do it. You have to implement it. And as much as the patient engagement of an individual or a family or a caregiver is contextualized, so is it for the care team, right? So none of this is you don't just pick it up and plop it down in your clinical practice and make it work. But I'm hoping some of these strategies really resonate with you and you say, yeah, actually, like we can totally start there. That's what I'm hoping you get out of today. So simplify information for everyone involved. might seem like a very straightforward strategy, but not something we always do great in healthcare. Be specific, like, what do you want out of this patient engagement? Is it with this one individual patient and there's a goal to improve a chronic disease outcome? Or is it that there's something you want to get their feedback on, a process in the clinical practice, some sort of outreach to the community? So what exactly do you want out of this patient engagement? Encourage goal setting. So I really alluded to this earlier, but I find often in my own experience that there is a disconnect sometimes between the clinical and non-clinical team, and there's no fault on anyone's part. But oftentimes we aren't afforded, as Anne talked about, two hours of charting and paperwork for every hour seeing patients. We're not often afforded a lot of time as clinical and non-clinical teams to connect and talk about these issues. So really protecting a bit of time around that and including patients in that, like, what is the goal for the patient with engagement? Like, do they want to hear from me? Probably, but like, why do they want to hear from me, right? And within the care team, what is our goal here? What are the expectations? Who is responsible for these kind of engagements after we determine what the goals of the team are? The other important thing is to avoid making assumptions when communicating with patients. So I have really messed this up many times. And I, in my clinical practice, work with a lot of newcomers to the United States. And I have frequently made assumptions about their desire to have that particular population that I see, their desire to have preventive care or women's health, or the assumption sometimes I make even about health literacy, that because someone is communicating with me in a certain language that perhaps they're going to read in that language. Like, even though I can translate things on my EHR, it doesn't necessarily mean that that particular family is able to read the language I just translated it into. So lots of assumptions from lots of different angles: content, what the priorities and goals of that particular patient or family are, and also the health literacy pieces, among many others. Making information easily shareable. So this may look different for different populations. I know in some of my older patients, they are really, I have a couple older patients that love Epic and they love being on my chart. And I have others who are like, you will never catch me actually opening that portal, right? So thinking about, how do I easily make this information shareable for this particular group of patients? Defining roles, again, I've mentioned this several times, but defining roles around patient engagement within the context of the care team. One of my colleagues who has taught me so much over the years, but she always says, you know what, it's a good day when our patient connects with one person on our care team. And sometimes and often it's not me. It's somebody else. And oftentimes it's a non-clinical part of our care team. That is golden. Right? If we can create a culture where we're all important and we're all connecting with the patient and engaging with them. Consider equity, and I mentioned this earlier, that's why I spent a little bit of time camping out on that concept, but consider equity in the context of equity in all of our proposed outreach. You guys have many awesome outreaches that were listed when we talked about your current patient engagement. So think about context and think about that role of the equity lens. And then ask when, and how patients want to be engaged. And sometimes that means you got to be really nimble. And I understand that's a challenge when you have a particular grant and you're trying to work on your deliverables. I have been there, but in the end, we have to do what's best for the patient and patients in front of us at the particular time. And that's really about engaging them when it's best for them. Another thing is team-based care to support patient self-management has been shown in the literature to be a really helpful form of patient engagement. So again, that's very contextualized to your organization. Who is on the team and who is trained and who is got the time and who has got the ability to do that sort of outreach or interaction with the patient. Patient-clinician team communication to facilitate shared decision-making. So it doesn't always have to be the clinician. It's the person or persons on the team that might be positioned most effectively to help with those shared decision-making type of engagements. And then mobile applications, of course, and part of the third objective for this session, we only have a few minutes left, but I have a resource that is, again, I mentioned constantly changing around how to engage with IT. And then I listed others because there are so many. We don't have a lot of time today, so I didn't go on and on and on, but the literature has many others. I tried to bring the ones that seem most pragmatic to this talk today. So I mentioned earlier that when I was asked to give this talk, the person who asked me said, you know, I think you should really talk about the patient engagement that you've done in your clinical practice. We don't have a ton of time, so I'm going to be very brief, but I did put in the slides, which you will have a copy of, a little bit more information. And if you want to talk with me about this further, I am more than happy to schedule a separate time. But I learned very early in my clinical practice, both as an individual clinician, family doctor in a practice, and also in my role as a medical director in our Medicaid managed care company, looking at the population, that I was not effectively engaging my patients. And many of my patients were living in poverty for many different reasons. And I believed in the notion of the patient driving the plan, but sometimes my patients were so stuck in that tyranny of the moment because everything was coming at them, that even in a shared discussion grounded in trust, we couldn't figure out like what they really wanted out of life, right? Because today was focused on food or transportation or some sort of traumatic event that happened. So I started looking at different ways to actually engage with my patients more effectively. And one of them was, it's called Bridges Out of Poverty is the general framework, but a program developed in that framework is called Getting Ahead in a Just Getting By World. So I've been doing this for a number of years with patients in my clinical practice and in several other places. And the idea here is that we spend time together walking through a structured facilitation to really begin to identify what it is that would help us communicate better. And so this is very labor intensive, not super easy to initiate, but I wanted to share it as one example. It is 16 3-hour sessions, and I ended up getting grant funding to be able to get patients to participate in this. But we identify patients as investigators, and now a number of patients who are graduates of Getting Ahead have become facilitators themselves and are facilitating sessions for other patients. So the idea is that they investigate the experience of poverty and of the impact of that on communication and their lives individually, but also in the community simultaneously. And so we collected data at baseline, the end of the program, 6 months and 12 months. And I have the data that we collected there. And again, I could talk about this for a really long time, and I don't have a long time, but I wanted to share that these are some of the domains that we collected. And these are really all critical for patient engagement. So understanding where people are with a lot of these resources and understanding how we can build on those strengths and how we can build up some of those others that maybe aren't identified as resource strengths. You'll notice that some towards the bottom are a bit intangible, right? Like integrity and trust, motivation and persistence, relationships, that's really separate from social capital, but related. And then knowledge of hidden rules. And this is one that I just wanna stop on for a minute. I have a slide to help it be a little bit more concrete for you. But most of us have grown up, not all of us, and I don't want to make assumptions about those of you because I don't know any of you on this session, but many of us in the professional world have grown up in the middle class, or at least we've gone through school in a very middle class setting. And so we've learned the hidden rules of the middle class. Some know the hidden rules of wealth, and some know the hidden rules of poverty. But oftentimes, for example, in our community health centers, our patients are learning and living by the hidden rules of poverty. And a lot of times the care team doesn't always know what those are. And there becomes a divide, an obstruction that does not enable patient engagement. And so that's one of the things that we really try to unpack in this particular program. The other thing we collected were life stability domains. And these are kind of interesting. I just wanted you to have an idea. But these also impact patient engagement, right? Like if someone's worried about one of these issues, that's going to be really hard for me to convince them to get a colonoscopy, right? So really understanding this has been essential to my ability to provide better care and our team's ability to provide better care. I just listed the modules so you can see what they look like, and you can look at them later if you desire. But this is the one slide. It's an example of hidden rules where around relationships, which is in primary care. Again, I mentioned that longitudinality, relationship-based, that oftentimes get to become a challenge in a high pressure clinical situation. So sometimes we make deposits to that relationship bank, that social capital bank, and those are the things on the left. But sometimes, and I'm guilty of this all too often, I make withdrawals from these. And so that's really an important piece of kind of thinking about patient engagement, like what are those interpersonal skills we're using? And when we get stressed or our clinic gets like explodes or clinical practice pressures are really high, like we sometimes default to the things we know as stress tools. And sometimes those result in withdrawals in the relationship bank we have with patients. And so there's no blame here. I'm just trying to raise the awareness about some of the ways that we can more effectively engage patients. I love this quote. I use it with our students as well as patients, but I'm just going to quickly read it to you. There's no such thing as a neutral educational process. And when I think of educational process, I'm talking about what we do with patient engagement, but also what we do in the formal educational system. Education either functions as an instrument that is used to facilitate the integration of the younger generation into the logic of the present system and bring about conformity to it, or it becomes a practice of freedom, the means by which men, women, and I would say this was written at a time where we didn't have a lot of focus on gender identity, but where we all deal critically and creatively with reality and discover how to participate in the transformation of that world. And so that's what I hope that we do in our culture for our patients in primary care, that we become a much more effective way of engaging our patients because we're getting constant feedback, constant dialogue, forward and backward about how we can better engage with folks. I'm almost at time, so I'm going to breeze through this really quickly, but these are some of the qualitative themes that have come out of some of the work we've done in this example of an engagement strategy. And I get it that this doesn't seem probably scalable to large scale clinics, but I wanted to give you an example of a creative, different way of engaging and like some really cool qualitative outcomes and quantitative outcomes. We will have a paper out pretty soon on this if you want to see some of the other outcomes and some self-reported accomplishments. So I just wanted to throw this in like, hey, check out the smoking cessation, right? Like check out the maintenance of sobriety, like engaging with patients on a personal level where they feel like they can own some of the interaction that they have with their care team and build social capital around that. That is huge. And you'll have this in your slides, but there's an embedded link for a video, which is really cool to watch. I knew we wouldn't have time today, but I wanted you to have it. All right, the final little thing here in this last moment is patient engagement and technology. So I give you the playbook. You can look at that later. But the key take-home points from this are consider your population, not making assumptions, like what is desired. And it may be multiple things desired. So you may have to prioritize that within your heterogeneous populations. But ask, right? Ask. Don't just check the box that you did patient engagement. Identify gaps in the clinical and patient and community. Like where are the expectations not aligned around engagement? Where are the expectations and the engagement not aligned around IT, right? Like I have some patients who absolutely will never check email and they're like, I will never know if you send me something on my chart. Okay, then we need to have a different way of communicating. Continually evolve your strategies. That's one of the things about this playbook. It's dynamic and continually evolving as IT changes. And then look for unique opportunities to engage. So I gave you one example. I'm not saying you need to use that, but you are brilliant people and we need you in primary care. And so as technology evolves, we definitely want to learn from you and each other as we think about different ways to engage our patients. So I gave you some summary take-home points. in each of the three learning objectives for today. And I know you're getting a ton of information in a half day. So I wanted you to be able, if this really floats your boat and you're like, yeah, patient engagement's my thing, I would love that. That's awesome. So I wanted to give you some, concrete take-home points that you can circle back to when you take this back to your clinical practice. And you got some resources, and we are right a moment over time. So Timmy, I'm gonna not do this poll and pass it back to you. I don't see any questions at the moment in the chat for me, but I want to challenge everyone to think about that one patient engagement opportunity that you'll pursue. Maybe it means just talking to your colleague about the definition. Maybe it means thinking about a new way to do some outreach. But I want you to really think about that and write it down for yourself right now. I'm, honor system, right? But do that, think about it. And I look forward to hearing more in the future. Pass it back to you, Timmy.
Thank you so much, Dr. Heidi. We truly appreciate your presence here and the information you have poured out into us. Our next topic will be with Kaylee, and I'll pull that up in a minute. Go forward. There you go.
Okay, awesome. Yep, I have control now. Thank you. All right, just a quick check. Can everyone hear me okay?
Yes.
Yep. Okay, great. Well, hi everyone. Good morning. Hope everyone's doing well. My name is Kaylee Hope, and I'm the analyst at the Maryland Primary Care Program. First, I wanted to say thank you so much to everyone for being here this morning. I'm very excited to be here with you all to discuss how to leverage Excel to track patient outcomes for the MDPCP beneficiaries at your practice. So with that, let's jump in. So to give you an outline of what the session will look like today, we're going to review the learning objectives. Then we'll do an overview of super utilizers and why they are an important area to focus on. Then we're going to learn how to identify super utilizers by leveraging CRIS reports and Microsoft Excel. And then you're going to have the opportunity to try this yourself. So it's going to be a little bit of an interactive session towards the end. And then at the very end, we'll have some time for some Q&A. So just a quick review of the learning objectives. Today, we will understand how to use Excel or Google Sheets to collect, organize, and analyze data. We'll learn how to use Excel or Google Sheets to track patient outcomes and assess program effectiveness. We will identify potential challenges in using Excel or Google Sheets, and then the strategies to overcome them. Okay, so to get started, before we get into some background information about super utilizers, I would like to allow everyone the opportunity to get set up and follow along if you would like to. So we will be using data that is pulled from the CRIS CRS portal, and you can access this data that is specific to your practice by going to the MDPCP reports, which is circled in red below here in the image. So feel free to, in the background, pull up CRISP as I'm going through the focus of today's session, which will be super utilizers. So as I mentioned, super utilizers is what we'll be focusing on today. So a brief overview of what they are. Super utilizers are patients with high medical costs from recurring, preventable inpatient or emergency department visits. and research from 2020 found that the top 1% of Medicaid superutilizers accounted for 25% of the entire 2020 Medicaid budget. So very extreme. As far as quantifying superutilizers, the Agency for Healthcare Research and Quality, or AHRQ, categorized superutilizers as patients who had 4 or more ED visits in a 12-month period. So under this definition, approximately 1% of MDPCP beneficiaries are superutilizers. And despite being such a small group, this population is responsible for approximately 21% of the total ER claim payments for MDPCP. And that is when we use the Q2 2023 attribution, and we look at the January 2022 through the January 2023 timeframe. So why should we focus on superutilizers? By focusing on superutilizers, we're able to help patients who often aren't getting the kind of care that they need. And as you saw in the data from the prior slide, there is a huge disparity that's occurring in this small group of patients. And it's up to us to step in and figure out how we can help these patients get the care that they need. And then I've included a quote from a 2015 journal article, and I'll just read it. It says, "Superutilizers are super detectors, helping to clearly identify system inefficiencies and their link to low value care." So with that, let's get into the Excel portion of learning how to identify the superutilizers in your practice. Okay, so I hope at this point everyone has gotten a chance to pull up the CRIS reports. But if not, no worries, this is all recorded. But once you're in the CRIS reports, first step would be to navigate to the inpatient and ER utilization report. And once you're in that inpatient and ER utilization report, you'll want to navigate where it has ER visits per K. And just a note before following step 2, you want to make sure that the time frame that you select is a 1-year period. And this is so that we can align with the official definition of a superutilizer, which measures the ER visits in a 1-year period. So for example, the time period that I'll be looking at today is January 2022 through January 2023. And if you wanted to look at the most recent time period available, you can go ahead and use that time period. It's the most recent one to date in the CRIS portal. But for step 2, you'll click on the box to the right of practice, and this should prompt a pop-up that looks just like what you see in the image to the right. And then you will click on the blue text that is circled in yellow that says ER count beneficiary details. So if you followed all those steps successfully, on your screen, you should see something that looks similar to the screenshot, except on here, obviously, the identifying information is hidden, but on your end, patient names, MBI, and the claim numbers will be listed. So for your next step, you'll click the Excel button, which is the circle in the top right on the screen circled in green. And when you do that, a prompt will appear warning you that you're about to download PHI, and you can click OK. And from here, I will start sharing my screen to show what your point of view should be once you have exported the file. Right. Can everyone see this okay?
Yes.
Okay, perfect. Okay, so as you can see, this file lists all of the claims within a specified time period. For myself, it would be January 2022 through January 2023, and it has MBI, beneficiary name, and the claim details. And for the purposes of this session, all of the identifying information that you see is entirely fictional. None of it is real. So depending on the size of your practice, you might get an export that has hundreds of claims. If we scroll all the way to the bottom, we'll see that this file has about 210 lines of claims, which can make it difficult to navigate or interpret. So in order to make sense of this data, I'm going to walk us through how to quickly and efficiently figure out who the highest ED utilizers at this fictional practice are. So the very first step, we want to click this tab in the top left-hand corner, which kind of resembles a sideways triangle. And doing so will highlight everything on the sheet shown. And then you will click the insert ribbon located on the top of the screen and proceed to the pivot table function on the top left side. And you should get a pop-up that asks you to select the table on the range, which we've already done in the prior step. So we can leave that as it is. And it asks where you would like to have the pivot table placed. And we can leave this as is as well. So we can hit OK. So this should have taken you to a new sheet that allows you to organize the data that you've selected. And we're going to focus on this menu on the right-hand side of your screen titled the Pivot Table Fields. And here you have all of the different aspects of the claims data, which we saw in the previous sheet. We have MBI, beneficiary name, primary diagnosis, claim payment amount. So since our goal here is to identify superutilizers, we want to get the count of claims for each individual beneficiary. And to do this, we'll start by dragging the MBI field. Sorry, did someone have a question?
Sorry, I hit it by accident.
Oh, no worries. Okay, I'll keep going. Okay, so we will drag the MBI to where you see rows. And then you'll see now that the sheet has each individual MBI for each patient listed in column A. And then next we'll drag the claim number field to the value area. And you'll see that Excel automatically calculates the sum of the claim numbers, which is not what we want. So in order to fix this, we will go to values and we'll click on the sum of claim number right here. And then we will click on the value field settings. And you'll see that instead of sum, you can select the count. So now you have the count of ER claims for each patient. And just doing a quick look, you'll see that most of these patients have 1, 2, maybe 3 claims, but there are a few outliers with more. And since there are quite a few patients, rather than going through and picking them out manually, we can choose to show only the super utilizers or those patients with 4 or more ER visits during the 1-year period. So to do this, you will click the gray drop-down button. And then you will click on value filters. And you will select greater than or equal to. And then you'll enter 4 to align with the AHRQ definition of superutilizer, since that's what we're looking at today. And what you will get is a list of all of the MBIs who would be classified as a superutilizer. So now that you have this list, you can definitely experiment and add other fields. You might find it useful to add the beneficiary name as well. So we would add that to row. And then you see, along with their MBI, we also have their name. And it just includes the count of claim number next to their name as well. And you can even add their primary diagnosis that kind of corresponds to each of their ER visits. So we can do this by adding the primary diagnosis to the row as well. So if we look at these claims and we start to scroll down, we'll see that some patients have very different diagnoses for each visit, with a few reoccurring. Looks like this patient has gone to the ED twice for chest pain. This patient has gone twice for dizziness and giddiness. Meanwhile, it looks like this patient has gone 6 separate times for nausea. So something like this could definitely be an opportunity to intervene and try to pursue some patient education, or just follow up with the patient and figure out what's going on there. But this kind of concludes the process for identifying superutilizers with Excel. So I will stop sharing my screen. And now I would like to give everyone the opportunity to try this themselves, and then we can regroup to ask any questions or share any interesting findings that are specific to your practice. And I know that some folks prefer Google Sheets. So if you're working with Google Sheets, I know the functionality is a little bit different there. So if you run into any issues, have any questions, feel free to raise your hand and come off mute. But for now, we'll take some time for everyone to try it themselves.
I have a question. I was having a hard time logging into the CRS. What was the report that you were demonstrating?
It is the ER and inpatient utilization report.
Perfect, thank you.
Just wanted to check in, see where everyone's at. Are there any questions so far? Do we still need a little more time? I'm going to interpret the silence. Is everyone working very hard. So I'll give everyone a little bit more time.
Hi, Kaylee. I popped a question in the chat that I just got about where the data came from.
Right, yeah, I see that. Let me see if I can go back to the slide that has the information of where the data came from. Okay, so it should be on this slide here. It's within the MDPCP module in the CRISP CRS reports. And once you're in the CRISP CRS reports, you'll navigate to the inpatient ER utilization report. Okay, I see another question in the chat. Can you remind me of how to get the sum of visits? So I will reshare my screen and go through that process again. So bear with me. Okay, let me know if you can see this okay.
Yes.
Okay, so in order to get the count of visits, first you'll want to make sure that you have MBI or beneficiary name, just the identifier for the patient underneath row. And then to get the number of visits, you will use claim number since for each visit, the claim number is unique. So a good way to count the number of visits. And we will drag that to values. And you'll see that you run into the issue that Excel automatically sums the claim number. And to fix that, you will click the drop down on the sum of claim number. You'll go to the value field settings, and you'll see that sum is automatically selected. So instead, you'll click count. You'll hit OK. And then you'll see that you have the count of claims for each patient. And then to identify the super utilizers specifically, you will go to value filters, which is in the drop down on the row labels cell. You'll select greater than or equal to. You'll enter 4, and then it will show all of the patients who have 4 or more claims or ER visits. Let me know if that clarified your question, or if you need anything additional. Okay, I see. A couple more questions came in. How is a super utilizer identified? What is the definition and why 4 visits? So a super utilizer is identified by the number of their ED visits, which is 4 or more. And this is the AHRQ definition. Officially, there isn't one specific definition, but various organizations kind of create their own definitions, and one that is pretty common is using the AHRQ definition, which is 4 or more visits. And I see another question. How do I get access to this? It's not on my CRISP. I see that we are almost at time. I think if you need additional assistance accessing that, definitely reach out to me after the session, and I'm happy to assist with that. But as far as everyone identifying the super utilizers at their practice, do we need additional time? I guess raise your hand if you have been able to identify the super utilizers at your practice. Okay, I saw, Jody, that you raised your hands.
Yes.
Did you have anything that stood out to you about the number of super utilizers, or just anything that stood out, anything you wanted to share with the group?
Yeah, very helpful. Our practice had 54 patients within the last year that had 4 or more ER visits, and those 54 patients accounted for 305 claims. When I look at it by diagnoses, many of them are primary care type reasons that we probably could have addressed in the office without them having to go to the ER.
Well, thank you for sharing. Anyone else care to share what they found? While we're waiting, I see another question that came in. Does the data have a 6-month lag? Yes, I think right now the most up-to-date data is through January 2023, so about a 5-month lag. But yes, that is what the current lag is with the CRISP reports. Okay, well, I see have about 5 minutes left. So just wanted to take some time to close out, see if there's any additional questions, comments about anything that we covered in today's session. Okay, well, I guess no questions or comments. So wanted to just close out and say thank you everyone for attending. And if you find that you have any additional questions, if you decide to rewatch this or try this yourself at a later date, feel free to reach out to me. Happy to assist. And then at the end here, just plugged in the article that I spoke about earlier in the session. I think it's a good read if you want to take the time to look at that. Right, well, I think it's time for a break, so thank you again.
Thank you, Kaylee, for that presentation. That was really insightful. Now we're going to, well, we're a little early, but break starts. And so we'll be seeing you in the main room shortly, where we'll be discussing cultural competence. So what you can do, do not exit, do not leave meeting, but leave breakout rooms so it takes you back into the main room. And then we'll see you there shortly.
Thank you. And let's see, can you all hear me?
Yes.
Perfect. All right, so my name is Jasmine Leonard, and I'm a Health Equity Enterprise Manager at Care First, and I'll allow Maya to introduce herself.
All right, hopefully you all can hear me too. Hi, everyone. My name is Maya Dean Polyak. I am one of Jasmine's colleagues at Care First Blue Cross Blue Shield. My title officially is I work as a pediatric population health strategy consultant at Care First, and I'm very happy to be here today.
Okay, great. So we are here today to talk about cultural competence. And before we get started, we want to let you know what you're in to expect. So our agenda is to go over some foundational knowledge. We'll go over definitions and key terms. Then we'll discuss some of the equity in Maryland, and then go into a deeper dive on exactly what cultural competence is, provide you with some examples, and then give you some recommended next steps. At the end of this presentation, our hope is that you understand the importance of cultural competency in primary care, that you can identify strategies for improving cultural competency in healthcare, and then that you can learn how to incorporate cultural competency in your roles. Also, feel free to put messages in the chat. We hope that this is interactive and that you feel like you can just ask us questions as we're going. So usually I start any of my presentations that are talking about cultural competence or structural racism in healthcare with this tweet. This is a tweet back in 2021 that came out from the Journal of the American Medical Association, and it says, "No physician is racist, so how can there be structural racism in healthcare?" This was a tweet that they were using to preview a podcast that they had, in which they essentially said that structural racism doesn't exist within healthcare, and that within the healthcare system, doctors, given the place that they have, like, that's just not enough. It's not a possibility. And so this came at the height of the COVID-19 pandemic and the racial reckoning that was happening within the United States. And I use this as a way to just show that these conversations are necessary, that these conversations have to happen, and that even the Journal of the American Medical Association can get it wrong. And hopefully after this presentation, you have a small insight into how you can get it right. So like I said, I want to start with foundational knowledge. So I'm going to go through a series of definitions, and hopefully you can put some definitions in the chat, but if not, we're going to get through all of them, okay? All right, so the first word is culture. And can anyone drop in the chat how you would define culture? There's no wrong answer. Yes, okay, customs, belief systems of a community, belief. Perfect. So yeah, so that is essentially culture. They're the integrated patterns of human behavior that include language, thought, communication, beliefs, customs, yep, institutions of racial, ethnic, religious, or social groups. Exactly. All right, and how do we define race? ethnicity, okay? All right, so for race, and this is a definition that I want to be very clear about. So when we define race, it is a socially constructed system of categorizing humans largely based on observable physical features or phenotypes, such as skin color and ancestry. So I think the important part here is it's a socially constructed system. It is not biological. Race can and does change with the system or with the society as it grows, as it evolves, and essentially we just want to be very careful in understanding that race is not biologically made. It's something that as humans, as Americans, we have designed and constructed and evolved over time. All right, ethnicity is our next word. So I saw that this came up with culture, it came up with race. And yes, ethnicity belonging to a particular group absolutely is a grouping of people who identify with each other on the basis of shared attributes that can be traditions, ancestry, language, history, society, culture, you name it. And what about implicit bias? I know this one is definitely a term that has been used a lot more. And in the state of Maryland, actually, providers are required to take implicit bias training. So hopefully we can get an answer for this one. Okay, so if someone says implicit bias occurs automatically and unintentionally. Yep. Any others? All right. Judgments, yes, yes. Implicit bias, it can hurt others. Yes, absolutely. So the implicit bias are our unconscious attitudes, our prejudices, our stereotypes that can manifest in many ways, can manifest in our criminal justice system, our workplace, school settings, and in the healthcare system. Someone also wrote unconscious favoritism toward or prejudice against people of a particular ethnicity. And yeah, so I think people are only direct messaging me, but I am getting messages. So thank you all for participating. All right. Explicit bias. So we know the implicit bias or the unconscious stereotypes. So what might explicit bias be? Explicit bias might be when it's mentioned. Right, these are going to be the overt direct favoritism. Yes, this is the overt type of bias. This is when we automatically have attitudes and beliefs and then we express them. And sometimes it can be as a perceived threat. So I fear that someone who does not look like me might do something to me, right? That's an example of explicit bias. All right, a few more terms. Social determinants of health. Another buzzword that hopefully you have heard before, that you have an idea of what the social determinants of health are. Identifying social needs that affect patients. They can be barriers to healthcare. They are where people live, work, go to church, etc. Yes, yes. So social determinants of health, someone wrote environmental conditions that affect a person. An example can be lack of resources. Absolutely, you all are spot on with this one. So social determinants of health are the conditions in the environment in which people are born, live, learn, work, play, worship, and age that can affect a wide range of health functioning and quality of life outcomes and risks. All right, we've got a couple more. Social structures. So similar to social determinants of health, but a little bit different. Does anyone want to social structures, offices, stores, hospitals, labs. Yep. Homes. Neighborhood. Yes, exactly. So the social structures are the policies, our economic systems, our institutions that have produced and maintained modern social inequities, but as well as health disparities. And often these disparities and these discriminations are along categories such as race, class, gender, sexuality, and ability. Last one, health equity. And this is by far my favorite term. I use it all the time. But does anyone want to give a definition of health equity? Having equal access to healthcare, yes. Access to healthcare services, fairness to all for healthcare, benefit of positive health enforcement for patients, regardless of the population, high level of healthcare to all. Yeah, so, and then working towards a system where people have the same opportunity for health and well-being, regardless of race, ethnicity, disability status, etc. Perfect, yes. So health equity is when everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. Yep. So perfect. I'm so happy that we're all on the same page with these terms. It'll help as we move forward. So one thing that we talked about with implicit bias is that it's stereotypes, right? It's sometimes those ways that we associate people with outcomes, we associate names. It can be harmless, like peanut butter goes with jelly, but sometimes there can be negative impacts of implicit bias. And typically when we give this training, we ask people to take an implicit assessment, a test that is dealing with age, right? And letting you know whether you have a positive or a negative association with age. But in lieu of that, what I have here are a series of articles and reports that have come out in the past couple of years explaining how ageism shows up within healthcare. And again, implicit bias is not an overt desire to be biased towards someone. It's just the associations that your brain naturally makes. Our brains are constantly trying to take shortcuts, and sometimes those shortcuts can result in harm. And so what we see here are a series of stories and reports that say that sometimes doctors can be ageist, that it's harming the older patients, and that it can negatively impact the health of the older population. As we grow as a country and have an older population, it's going to be important to understand when you potentially have negative assignment or when you have negative association with older populations. If you believe that they potentially are less able to follow directions, or if you feel like that they aren't telling you a whole story, right? These are ways in which implicit bias can show up. So the next thing that we wanted to talk about is equity in Maryland, but two key terms that we didn't discuss were equality and equity. So here I have two pictures that are taken from the Robert Wood Johnson Foundation, showing an example of equality and showing an example of equity. In the chat, can you give me anything that stands out about the differences between the equity picture and the equality picture? The equity picture has a ramp, yep. It also has signs and speakers, yep. Sound with the equity photo, yes. There's stop and go signs, yes. So what you see with this equity photo is that it's a lot easier for everyone to get across the street or everyone to move at this intersection because there have been signs put in place, there's been visuals put in place, and it's allowing anyone to get to the next side of the road, right? But when we do equality, we're saying that everyone gets the same thing. So everyone has a sidewalk, everyone has an opportunity to potentially cross the street, but for someone who might be disabled or someone who is elderly or someone who potentially cannot see or hear, how do they cross the street? Yes, they have the opportunity, but how do they get there? And that's what equity is. Equity is saying that everyone gets exactly what they need and that you understand the barriers and the circumstances, the conditions, the social determinants of health, the social structures that are in play that might prevent them from being able to get across in the same manner. So let's take a look at equity in Maryland. So Maryland is a state like all other states in the country that have had disparities prior to the COVID-19 pandemic. The COVID-19 pandemic highlighted the disparities, but they were there before. And what you have here are two different graphs that are showing some of the disparities based on race and sex and geography in the state of Maryland. So what you can see with the bar graph is that there is a different life expectancy for white versus Black people in Maryland, as well as males versus females. In the graph of Maryland, what you see is the age-adjusted death rate based on geography, based on county. And what we know of certain counties within the state of Maryland, the darker colors, those are going to be those that have a significantly higher rate, a higher death rate than those that are in the lighter color. Even the ones in the middle kind of greenish scale they are not significantly different. What we know about the counties in Baltimore City, Baltimore, Dorchester, Wicomico, these are counties that are going to be disproportionately Black or disproportionately lower in socioeconomic status. When we compare those to counties like Montgomery County, Howard County, Frederick County, we're looking at counties that are predominantly white and that have higher socioeconomic status. So there are differences and disparities in the state of Maryland. The state of Maryland is not equitable, just like the United States is not equitable. When we look at the leading causes of death, like heart disease and diabetes, there are additional disparities. When we look at heart disease, it's one of the leading causes of death and actually accounted for 23.1% of all deaths. But our Native American and American Indian population have higher prevalence than all other racial groups when we look at the data. Diabetes, being the sixth leading cause of death in Maryland in 2018, also has disproportionate rates, with non-Hispanic Black population having twice the rate of non-Hispanic whites when looking at diabetes. So again, really wanting to hone in on the fact that there are differences, there are disparities here in the state. This is another graph looking at the life expectancy. And again, you see the juxtaposition of life expectancy as low as 56 years in Baltimore City, in Baltimore County, compared to that of Howard County, Montgomery County, where people can live up to 81 to 97 years old. So again, when we're looking at why social determinants of health are important, why cultural competence is important, it's so that we can get to that end goal of health equity.
All right, I'm going to take over for Jasmine here. So, now knowing that these disparities exist, as Jasmine talked about, let's pivot to cultural competence to better understand how to take action to improve quality of care for patients. And if I'm looking up, sorry about that, I'm just operating from two different screens here. All right, next slide, please. So first, let's discuss some key terms. As you can see, the ones on the slide here all pertain to cultural competence. So just to kind of make sure that everyone's on the same page here. First, we have cultural competence, which, as you can see on the slide, it's a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals that enables effective work in cross-cultural situations. So cultural competence as a concept was introduced only in the 1990s. It hasn't been around that long when it became a standard for patient-centered care. In healthcare, cultural competence can look like many different things. You can provide documents in more than one language, explaining patient care at a 5th grade reading level, acknowledging a patient's chosen name or a patient's pronouns, for example. And then from cultural competence, other things stemmed from it, right? Cultural competence helps introduce new terminologies, new ideas, a lot like, cultural humility and structural competence, which are our next two terms on the slide here. We've got cultural humility. And I know sometimes there can be some confusion between humility and competence. So to kind of clear up that confusion, Cultural humility is the ability to reflect and critique one's own ability to learn and understand someone else's culture and beliefs. So hopefully that clears up any confusion between, cultural competence and cultural humility. And then our last term here on the slide is structural competence. And structural competence is basically a conceptual framework integrating the impact of social structures, SDOH, with a call to action of healthcare professionals to recognize how, historical institutions, markets, healthcare delivery systems, how they shape symptom presentations when you see your patients. Next slide, please. All right, so now that we've discussed some key terms, let's take a look at some of the existing disparities, specifically in healthcare, and how cultural competence can help address those disparities, reduce those disparities. So as we can see here, we have a couple of facts. The first one is about language and communication barriers. These affect the quality of healthcare that patients receive. Of the 37 million adults in the US who speak a language other than English, nearly half of them report that they speak English less than very well. And, we know that interpreter services aren't always available during a healthcare visit, which can, greatly influence the quality of care that a patient receives. In addition, low health literacy affects patients and their quality of care. People with low health literacy skills tend to use more health services with an estimated cost in the billions in additional healthcare expenditures. In addition to health literacy and language, race is another factor. Black Americans, Latinos, and Asian Americans are more likely to report that they would have received better care if they had been a different race or ethnicity. And Black Americans specifically are more likely than other minoritized groups to feel that they were disrespected during a healthcare visit. So, we see all of these disparities in healthcare settings. So, how can cultural competence help address some of these issues, reduce these gaps? So addressing SDOH specifically through culturally competent care can result in several positive outcomes. One of those is that a greater financial return on investment. In addition to financial returns, we also see, culturally competent care, reducing provider burnout, and also obviously improving patient experience when seeking healthcare and when receiving healthcare. Next slide, please, Jasmine. All right, so, now that we've discussed the terms, the facts, let's talk about application, right? What next steps do you plan on taking in your positions, in your healthcare settings to improve patient experience? Next slide, please. So before we get into the actual concrete strategies, let's break it down and, let's look at, the steps it takes to just make a change in general. So some of you might be familiar with the trans-theoretical model of behavior change. Whether you are or you aren't, don't worry. You can find a brief refresher or an introduction to the model here on the left side of the slide. Now, this model takes us through the progression of how behavior change occurs. So first up, we have the pre-contemplation phase, which is basically a stage where a person is not quite ready to consider making a change just yet. After pre-contemplation, next comes the contemplation phase. This is where a person starts to consider that, there may be an issue and some room for improvement. After that comes the preparation phase, where a person prepares to make a change. Perhaps they take stock of and gather the resources that they will need to make the change happen. That might be timing, physical space, supplies, staffing, financial resources, etc. So after you prepare, it's time to move into the action phase, actually implementing the change that you want to make. And once the change has been implemented, then comes the maintenance phase. Now, I want to pause here and just kind of emphasize the maintenance stage. You know, this stage often gets overlooked as just a phase to continue the change moving forward. But I want to take a moment to kind of say it's more than that. You know, maintenance isn't just about maintaining this new change, it's about evaluating the change. You know, is this change accomplishing the goal that it was intended to? What's working? What could be better about the process? So make sure not to overlook this phase when implementing change, because as you can see in the model, behavior change is an iterative process. It's not a once and done deal. And if you're truly invested in making a change to make patient care more culturally competent, it must be a continuous process, because cultural competence in itself, you know, continues to be evolving. So, you know, switching gears from the behavior change model a little bit, let's look at the right side of the slide. On the right side of the slide, you'll see a modified version of the social ecological model. And this model is here to help identify who or what your change should impact. So for example, is the change you want to make intended to address someone at the individual level? Maybe it's intended to address something on the interpersonal level, perhaps among your colleagues. Or is it intended to impact something larger, something like policies, regulations, etc.? So now it's time to put it all together. Let's bring these two models together, and I'd like to ask you all a question. So this is, again, an interactive portion, so feel free to post in the chat. So in looking at the behavior change model on the left, what do you think is the best phase in which to consider or decide the level of impact you want the change to have? And I'm going to put that in the chat just so you know, everyone can see it and then can post in the chat. All right, and feel free to either directly message me with your answers, or, you know, you can send it to everyone if you have that capability. All right, I see someone says 2, contemplation phase. All right, any other? All right, another taker here. Someone says preparation. We've got pre-contemplation. We've got another preparation phase. Lots of preparation phases. All right, we've got some contemplations, a lot of people saying preparation. All right, and I just want to note here, there's no wrong answer. I just like to see, you know, typically where everyone would fall in, you know, in considering the level of impact. All right, I think the overwhelming majority are saying preparation. Thank you to those of you who participated. Like I said, no wrong answer, just like to see where everyone's at with that. I think personally for me, I'd probably consider it at the preparation stage. But I also want to note, and you know, I don't think anyone put this here, but it's also something worth considering at the maintenance phase, right? When you're evaluating how your change is working, you know, thinking about, is this change, you know, impacting folks at the level that I want it to, or that I intended it to? And if it's not, how can we tweak things? How can we change things to make sure that it's accomplishing that level of impact? Or maybe it is accomplishing the level of impact. But that's definitely something that you can also consider at the maintenance phase. All right, next slide, please, Jasmine. All right, so now that we've kind of talked about it in general terms of making a change, now we can get to talking about concrete strategies, right? So how can providers and healthcare staff make a difference in your offices? Well, we've got a couple recommendations here. The first is to recognize the pervasive legacy of structural racism and implement changes at the practice to reduce disparities that have been perpetuated by structural racism. So one example of this in action would be to seek out resources, continuing education opportunities, and not just take those trainings, those education opportunities, but to bring takeaways back, bring actionable ideas back with you from those trainings and bring them to your colleagues, you know, discuss during your strategy meetings, during your monthly meetings, you know, really kind of bring those takeaways back into your office so that you can implement change. And again, this is an ongoing process, you know, evolving process. That's why, you know, it's great to kind of seek out those continuing education opportunities. All right, additionally, we recommend addressing gaps at the intersection of healthcare delivery and public health. Remember that, you don't have to be the end all be all solution. You can bring in community partners to help you reduce disparities, right? So one of the practices that I work with, it's a pediatric practice, and they have a partnership going where they screen patients in the office for food insecurity using the Hunger Vitals. And then they partner with the community food bank. So if a child screens positive for food insecurity in office, the physicians can then write a prescription for the child, and the child and their family can then go fill that prescription at the local community food bank and get food for themselves and for their families. So that's just one example of how you can pull in public health and community partners to help you. And I see someone, all right. And then in terms of another recommendation, we have strengthening access and quality of care in marginalized communities. An example of this would be contracting with an interpreter service to better care for patients whose first language is not English. And if you want to take it a step further, look into in-person and virtual options. The pandemic has caused a huge rise in virtual care options. So make sure that, you're also looking into virtual options in terms of interpretation services. And then our last recommendation here is to improve cultural competence and the understanding of diverse populations. One example would be asking for and honoring a patient's pronouns and chosen name. You can mark that in your EHR. You can make sure that when you review patient charts before the patient comes in, everyone is on the same page in terms of referring to that patient with the pronoun that they have. All right, next slide, please, Jess. All right, and now we have some concrete takeaways for you all. These here are 5 recommended activities for all providers and staff. So the first one, complete at least one implicit assessment test. And some of you may be familiar with this test. It's online, and you can take it for a number of different, aspects. And basically, it helps you understand implicit biases that you might hold. This is a great assessment test to take if you're getting the conversation started. I know a lot of trainings or a lot of discussions often start with having folks take an implicit assessment test of their choosing. They have one on race and ethnicity. They have one on LGBTQ plus. They have one on age, religion, etc. So you can choose which one you'd like to take. And people generally find this pretty interesting to see, what implicit biases they may hold, but that they may not be aware of. Another step you could take is to complete a health equity training. There are lots of health equity trainings out there. We have some through Care First. If you Google health equity trainings, you can find a bunch. The Office of Minority Health is another great resource. They have a database of training centered around health equity and reducing health disparities. Another option is to complete the primary care self-assessment checklist. This checklist is basically intended to increase awareness and sensitivity of personnel to the importance of cultural and linguistic competence. Another option then is to, get started identifying a practice strategy to improve cultural competence in your office, in your place of work. And then once you've identified it, it's time to implement. Implement that strategy to improve cultural competence. And again, like I said, evaluate it, continually update it. Make sure that it's not just a once and done check a box thing. It's something that you return to. It's something that you discuss. It's something that you accept, patient feedback, right? To understand how best to execute the strategy and keep it going. Next slide, please. All right, now we're moving into our portion of Q&A. We have a couple questions for you all. Again, this is going to be an interactive portion. So I'd like to ask you all at this point to go ahead and chime in the chat with your answers. So Jasmine, if you could just advance the slide, please. All right, so our first couple questions here. Number 1. All right, and it looks like we have a poll up, so feel free to answer on the poll or in the chat. If you answer in the chat, just please make sure that you send along the number of the question that you're responding to so that we know. But go ahead and enter your answers in the poll. or in the chat. And I see we've already started to get a couple answers, so thank you to those of you who are answering now. Looks like we're getting a lot in. Okay. Looks like we're getting pretty good consensus on the first question. Let's see. All right, we still got folks chiming in, so it's not too late. If you're just looking at the poll now, feel free to answer in the poll or in the chat. I see some folks are answering in the chat. Thank you to those folks who are answering.
And it looks like we're 32%. So I think, do we want to get it to 50% and then we'll close it?
All right, that sounds good to me.
All right.
All right, folks, we're creeping up, getting close to 40% here. Let's see if we can get 50%. If you're nervous, the answers in the poll are completely, anonymous. We can't see who answered what, so don't worry. All right, we're at about 45%. Let's see if we can get
so close.
All right, 48. All right,
hit 50. Perfect.
All right.
And I see that we still have some people that answered in the chat. So I think we exceeded our goal. I appreciate the engagement.
Yeah.
All right. So let's end. I'm going to share the results out with everyone. And so let's go over the answers. All right. I'm going to stop sharing now. And let's actually discuss a little bit for some of these answers. So the first question was, race is a biological system of categorizing humans based on observable physical features, phenotypes such as skin color and ancestry. Is this true or false? The majority said that it was true. Does anyone want that answered false, explain why this might not be the correct answer? And feel free to put it in the chat. Yes, because it says biological, race is a social construct, not biological. Exactly, yep. So that's the key distinction here, that race is socially constructed. There's nothing biologically that we can step on, stand on that will indicate someone's race. And actually, when we look at it genetically, people that are within the same race have more genetic diversity or difference from each other than those who are in different races. So yes, race is a social construct. All right. Number 2, cultural competence first emerged as a concept in which decade? So this one, I think, was a listening activity. Maya gave us the answer to this one. And I can't remember. Maya, was the majority right?
Yes, so it looks like the majority, 38%, said 1990s, which is the correct answer.
Perfect. So great listening ears. All right. And then number 3. So I see we have a question on this. So an example of how you can make your office culturally competent is, and we have options of make all bathrooms gender neutral, ask new patients their primary language, make all handouts and signs accessible to a 5th grade reading level, or all of the above. And so this was all of the above. And I see that we have a question on whether you should ask a patient their preferred language versus their primary language. So you can ask both. I think the terminology as preferred pronouns, chosen names, and all of this is just changing every day. And so that's why it's important, like Maya was saying, to continue in the evaluation and the maintenance phase of behavior change. But the preferred language or primary language, both are appropriate questions to ask. And just ensure that what you're asking, you kind of know what you're hoping for in terms of information. Is it that you want to know the language that you should speak to them in when they come into the office? Or is it something that you're trying to do in terms of primary language and making handouts and signs? Do you need to know how many languages to push out in terms of handouts and things like that? So both are absolutely fine and would help to make people feel more seen and more visible within the office. So Maya, I think you have some other questions for us, right?
I do have a couple more questions. It looks like we have a couple more minutes. So let's go ahead and do some of those. So I'm gonna post them in the chat. So hopefully everyone can see them there. So the first one that we have here is a multiple choice. Blank are environmental conditions in which people are born, live, learn, work, pray, and play that affect overall health and quality of life. And then we have a couple options here. A is social structures. B, social determinants of health. C, social norms. Or D, factors of health. All right, we got a lot of A's. We have one SDOH, which is B. All right, give it about maybe 30 more seconds. We'll see a couple B's come in. All right, I see a couple more B's. I see a C, which is social norms. Another B. All right. So we're running low on time here now. So I'm going to go ahead and say that those who answered B are correct. Social determinants of health. All right. All right. Should we do, let's see, maybe we have time for one more?
Yep, let's do one more.
Okay. All right. Our next question here. All right, and this one is also a listening activity. I mentioned it in one of my slides. Providing structurally competent care can result in which of the following outcomes? A, improved patient experience. B, reduced provider burnout. C, return on investments. D, all of the above. All right, I'm seeing a lot of D, all of the above.
Lots of D.
Yes. All right. Give it 10 more seconds here. All righty. Looks like everyone got that one. It is, in fact, D, all of the above. And I think we're just right up against time here. So we can probably wrap it up here. I want to thank everyone for their participation. I know we had some interactive portions, so I really do appreciate everyone chiming in. Thank you so much for having myself and Jasmine. Jasmine, if you want to say anything else, feel free.
No, I think this was great, and I'm excited that so many people were engaged, and hopefully you come out having learned something from our presentation. So thank you.
Thank you so much, Jasmine and Maya, for such a great presentation and such an engaging one as well. So at this point, we will go ahead and open the breakout room again. So just to reiterate, for those that are in the clinical track, you'll stay in this main room. That will be the session focused on social needs. For those that are in the non-clinical track, you'll be going to the breakout room, and that session will be focused on diabetes prevention and management. For those who were already able to go to the breakout room, you should be able to just head back. For those who are new or have recently joined, let us know and we can add you to that room if you're having any difficulty. Otherwise, you should be able to self-select and join a breakout room, but let us know if you experience any issues.
Hello all, welcome to the breakout room. Kimberly will be talking about diabetes prevention and management. Kimberly, you now have remote access.
Thank you, Timmy. Hello, everyone. I'm Kimberly, and today I'll be speaking about diabetes prevention and management. So a little bit about me. I am an alumna of the coordinated program in dietetics at Howard University. I'm also an inaugural member of the CAR STEM Scholars Program at Howard University. That program's aim is to increase the amount of minorities getting terminal degrees in PhDs and MD PhDs. I'm also a registered and licensed dietitian in the state of Indiana. My clinical specialties include acute inpatient services, critical care, and general outpatient services, ranging from anything from endocrine, weight loss, diabetes, etc. And I'm also an incoming immunology PhD student at the University of California, Davis. So the content outline of my presentation is as follows. Presentation objectives, review of diabetes mellitus, review of oral and injectable diabetes medications, diabetes action plan, leverage your role as a non-clinician, why does compliance matter, review of resources, review of Maryland primary care program resources, a case study, and references. So presentation objectives. At the end of this presentation, participants will be able to understand the basics of diabetes for non-clinicians, leverage your role on patients' care team to support diabetes prevention and management, identify resources for patients to manage their diabetes, and review existing MDPCP resources. So if you could kindly take 15 to 20 seconds to answer these questions in the chat, please numbers 1, 2, and 3. I would love to see your thoughts and knowledge on these questions. I could also read them to you. So question 1 is, what percentage of the population has diabetes? Number 2 is true or false. Rapid active insulin works about 5 minutes after injection. And true or false, which is number 3. Nationally, the YMCA has a diabetes prevention program. Okay. So I see 25% in the chat. See 30% true. Please kindly put your numbers next to the answers next to numbers. 45%, 3 is false. Okay, 60% true. False, true, true, false. True. Okay. Okay. So I'm going to not share the answers until the end. We're going to ask these questions again to see if we've maintained the same amount of knowledge, gained knowledge, and see if your answers change. So stay tuned. Okay. So diabetes mellitus, often called diabetes, is a group of metabolic diseases characterized by hyperglycemia or high blood sugar. So too much sugar in the blood can cause serious, sometimes life-threatening health problems. And 37.3 million people have diabetes in the United States. The percentage is 11.3% of the US population. Pre-diabetes may or may not progress to diabetes, which is a reversible state between normalcy and diabetes. And there are 3 types of diabetes, and they're classified by what causes it. So there's type 1 diabetes, type 2 diabetes, and gestational diabetes. Okay, so food gives your body energy and is made of 3 macronutrients: carbohydrates, protein, and fat. So during food digestion, carbohydrates, or carb, primarily and quickly break down into glucose, which is blood sugar, and this is carried by the bloodstream to various organs of the body. It is used as an energy source in the skeletal muscles and liver, and insulin is a hormone made by your pancreas, which is also an organ in your body. It is needed to keep your blood sugar from getting too high. So insulin helps move glucose, the blood sugar, from your digestive carbs into your cells. So glucose or blood sugar fuels the cells. It gives cells energy. And in a healthy individual, the insulin binds to its receptors on a target cells and is taken up into the cell. So as you can see here on this image, the blue outline, the dark blue outline is the stomach and kind of the small intestine starting there. And green is the pancreas, the light blue is the bloodstream, and then the white box outlined in dark blue is a cell. So as you can see, number one is food enters the stomach. Number two is foods that have glucose in them, such as starch, fruit, milk, and sweets. They are changed into glucose when they're broken down. So these are the red dots on the screen. And then they enter the bloodstream, which is number 3. And number 4, the pancreas, that green outline, it releases insulin, which is the hormone that helps it get into the cells. And as you can see here in a healthy individual, those yellow triangles bind to the green circles in the cell, kind of like a lock and key system. And then the blood sugar enters the cell, those red dashes. So that's how it works in a healthy individual. Okay, so type 1 diabetes is classified by the pancreas making very little or no insulin for your 24-hour insulin needs. This is autoimmune, meaning that those cells in the pancreas are destroyed by the immune system by mistake. And those cells are specifically the beta cells. So type 1 is characterized by early onset symptoms, commonly starting before or suddenly at the age of 20. It does have a peak age of diagnosis, ages 9 to 14, and it usually affects people under the age of 40. So type 1 diabetes is normally managed with insulin injections, and type 1 diabetics are therefore insulin dependent, or people with diabetes are therefore insulin dependent. So type 2 diabetes is the most common form of diabetes. The body doesn't properly use insulin that it makes. So the cells don't respond to insulin like they should in that image I showed you. And this is called insulin resistance. The cells are not responsive to insulin and therefore cannot import glucose. So glucose stays in the blood and causes high blood sugar. Obesity, inactive lifestyle, and unhealthy diet are associated with a higher risk of type 2 diabetes. This usually appears in people over the age of 40, but in recent years, it is becoming increasingly more common in younger people of all backgrounds. So gestational diabetes means having diabetes during pregnancy. It is a transient form of the disease, which may resolve after giving birth. Having gestational diabetes puts you at a risk of type 2 diabetes in the future, and giving birth to a baby that's over 9 pounds also puts you at risk for type 2 diabetes. If a fetus is exposed to the blood sugar or glucose for a long time in the womb, it is more likely to be diagnosed with diabetes as well. So how are these diagnosed? There are multiple methods of testing. There's a fasting plasma glucose test, and if it's greater than or equal to 126 milligrams per deciliter, then you have diabetes. So fasting is considered as no caloric intake for at least 8 hours. And there's also another way of testing, which is the 2-hour plasma glucose. If that's greater than or equal to 200 milligrams per deciliters during the oral glucose tolerance test, or the OGTT, then you have diabetes. So this test is formed by using a glucose load that has 75 grams of glucose dissolved in water. So to put that into perspective, 75 grams of carbohydrates or glucose is approximately the amount of carbohydrates in 5 slices of bread or 20 ounces of juice. So please note that all breads are not made the same and they have different weights and densities. So this is like a standard 15-gram 1 slice bread. This tests the OGTT. It's most commonly done to check for diabetes in pregnancy. So it's if you do have a number greater than 200 for that one, you most likely have gestational diabetes. The A1C score greater than 6.5% is the hemoglobin A1C or an HbA1c. It is a simple blood test and it measures your average blood sugar levels over the past 3 months. So in a patient with the classic symptoms of hyperglycemia or hyperglycemic crisis, they can also draw a random plasma glucose on you. This is common in the hospital, and if it's greater than or equal to 200 milligrams per deciliter, then you also have diabetes if it's paired with the classic symptoms of blurred vision, frequent urination, or increased thirst. So people who have diabetes need to look after and manage their diabetes on a day-to-day basis. So blood glucose testing gives an accurate picture of someone's blood glucose level at the time of the test. So this can be done with a prick of a finger and a test strip or a continuous glucometer, and that's placed on the arm, and the results are shown on an app on your phone, and you don't have to take it off. You could shower with it on. So oral and injectable diabetes medications. So medications are used to help your blood sugar levels within your target range of 80 to 130 milligrams of deciliters before you eat. This is if you have diabetes. Skipping meals and not using your medications properly can result in missing your target blood sugar range. So as you can see on the slide, if you do have diabetes, we would love for your A1C to be less than 7%. Preprandial means before eating. We love that range to be 80 to 130 milligrams per deciliter. Peak postprandial means after eating. We would love that range to be less than 180 if possible. I say if possible because everyone is different and they might have multiple diseases, which we call comorbidities, that can affect those ranges. But poor medication adherence in type 2 diabetes is well documented to be very common and is associated with inadequate glycemic control, increased emergency room visits, and hospitalizations. So there are different kinds of insulin and different peak times. These are injectable medications. So remember we spoke about insulin's role in helping glucose enter the cells at the beginning of the presentation. So the insulin onset, peak, and duration onset is when it starts to work. So the peak time of insulin is the time it's working the hardest to lower your blood glucose. So as you can see here, there are 4 different types of insulin that we commonly give. I can only speak from a hospital and outpatient perspective. And so there's rapid and fast acting, there's short acting, there's intermediate acting, and there's long acting. So the onset time for rapid or fast acting is 15 minutes. That means how long after you give it does it start working. The peak time is 1 hour and the duration is 2 to 4 hours. And an example of this is Humalog. For short acting, the onset is 30 minutes. The peak time is 2 to 3 hours. The duration is 3 to 6 hours. And an example of this is Novolin. For the intermediate, the onset is 2 to 4 hours. The peak time is 4 to 12 hours. The duration is 12 to 18 hours. And an example of this is Relion. For long acting, the onset is several hours. There's no peak time. It lasts about 24 hours. And an example of this is Lantus. So there are also non-insulin medications. One of the most popular is metformin. So metformin is taken orally, usually in a pill form, and it lowers blood glucose levels primarily by decreasing the amount of glucose produced by the liver. So metformin also helps lower blood glucose levels by making the muscle tissue more sensitive to insulin so that that excess blood sugar can be used for energy, and it's usually taken daily. So diabetes action plan. If a patient has low blood sugar during or after exercise, we recommend the 15-15 rule. You want to check the blood sugar, and if the reading is 70 milligrams per deciliter or lower, give 15 to 20 grams, which is 1 carb count of carbohydrates to raise the blood sugar. Examples of 1 carb count is 4 glucose tablets, so 4 grams per tablet, or 4 ounces of juice, which is half a cup, or regular soda, not diet. So diet soda or juice or tea will not have any sugar in it, and you really need the sugar in a scenario like this to raise your blood glucose up. Or 1 tablespoon of sugar or honey. And then we wait 15 minutes and then you check it again. If it is still below 70 milligrams per deciliter, give another serving of 15 grams of carbohydrates. And then if necessary, you wait another 15 minutes and repeat the process until it's up to that 80 that we would love it to be. Okay. A typical medical intake form for diabetes assessment for a clinician may include the following key areas: the last A1C and A1C goal, the last eye exam, the last foot exam, frequency of glucose testing, blood sugar goals, diabetes education classes or affiliation with a diabetes center, type of glucometer, signs and symptoms or low blood sugar and high blood sugar. So signs and symptoms of low blood sugar would be nervousness, shakiness, fatigue, and confusion. And that's called hypoglycemia, is low blood sugar. And then high blood sugar's sign and symptoms are thirst, hunger, fatigue, frequent urination, and blurred vision. And the medical term for high blood sugar is hyperglycemia. Leverage your role as a non-clinician. So in a primary care provider's office, there may be the following personnel: medical transcriptionist, medical biller, medical records clerk, a medical assistant, laboratory technician, a phlebotomist, a medical office manager, an LPN, RN, NP, PA, MD, or DO. But the key here is team-based healthcare. Is the provision of health services to individuals, families, and or their communities by at least 2 health providers who work collaboratively with patients and or their caregivers to accomplish shared goals within and across settings to achieve coordinated, high-quality care. So medical assistants provide excellent support for some care management activities, such as identifying patients in the registry who need follow-up care, or calling to set up physician or care manager visits, or keeping medication lists and other healthcare encounters up to date. So sometimes the patients may let the medical assistants know more about themselves than the provider because they feel more comfortable with the medical assistant. So the typical 15-minute primary care office visit is widely considered insufficient for meeting the educational and treatment needs of vulnerable patients with diabetes and other chronic conditions. So we have to make the limited time we have with the patients count. I do want to clarify that most initial visits are longer. However, from the moment they step into the office until the moment they leave, we should take all opportunities to prevent progression of disease. So you might be wondering, how can I help this patient achieve their goals? Well, the overall goal of healthcare as a team is to have adherence and compliance to medical and lifestyle interventions. So patient compliance is defined as the degree of adherence of a patient to a prescribed diet or treatment, and whether the patient returns for re-examination, follow-up, or treatment. For example, if a medication is prescribed for twice a day, 100% compliance means that the patient takes it twice a day as prescribed. Another example of this is, let's say a lab test is ordered by the MD and the receptionist schedule it. If the patient misses the appointment, then that's non-compliance. So why does compliance matter? Over time, diabetes can damage blood vessels in the heart, eyes, kidneys, nerves. People with diabetes have a higher risk of health problems, including heart attack, stroke, and kidney failure. Diabetes can cause permanent vision loss by damaging blood vessels in the eyes. Many people with diabetes have developed problems with their feet from nerve damage and poor blood flow. This can cause foot ulcers or pressure injuries in the feet, and it may lead to amputation on not just one leg, but maybe the other, or maybe just some toes, or maybe all the way up to your hip. And it's important that they don't walk barefoot and that they do not cut their own toenails. Women with gestational diabetes are at an increased risk of complications during pregnancy and at delivery. And these women and possibly their children are at an increased risk for developing type 2 diabetes in the future. So for every 1% reduction in that hemoglobin A1C score, let's say from 8% to 7%, the risk of developing everything we just covered drops by 40%. That's a drastic change in outcome from a seemingly small change in the number. So that's a big deal. So resources to leverage your role as a non-clinician. These resources or opportunities involved human capital and paper handouts and websites. So what can you do? At the end of the appointment, the receptionist can let the patient know which registered dietitians are in their network for referral, or even schedule with a registered dietitian if it's an interconnected system that lets you schedule right away. So giving patient the handouts that the doctor wants them to have when they go to checkout, or at an end of visit summary printout, will help them remember and keep it in the back of their minds. And if you have an electronic health record or electronic medical record, EMR moving forward, tell the patient about it and give them handouts or verbal instructions on how to set it up on their phones or on their home computer. So if there's also a telehealth option, consider the step-by-step instructions for patients who may have difficulty using it. Providing tracking sheets for daily blood glucose level is helpful, as again, handouts is just part of what I do daily, but handouts in multiple languages based on the patient populations that you serve is a great idea. And you could also incorporate this with your EMR. So EMR messaging, you could send the handout through the EMR, or you can just communicate through the EMR, just sending a reminder that the appointment is scheduled for tomorrow, or we've seen that you haven't scheduled your registered dietitian appointment. We kindly advise you to. And a key advantage to this when you have access to an EMR as a patient is documentation. You could see everything in one place, and you could also see, okay, well, the doctor said my A1C last week was this amount and now it's this, and you have it right there. So you can also attach the patient chart so it can provide context for the patient in question. And then again, certain tools can be sent via the EMR, templates for documenting their own self-charting or self-management goals, like that tracking sheet that I mentioned. And it's also a mechanism for following up. On a social aspect, having the paper version or QR code or app link to the bus or train schedule that is closest to your office to get to help the patient get to the appointment on time is removing a barrier for these compliances as well. Reputable sources such as eatright.org or diabetes.org, these will be addressed in another slide, is another resource. Adding these to your role in accordance with a new update to the American Diabetes Association 2023 Standards of Care in Diabetes Guidelines. They focus on social and community-centered goals and interventions. So there are notable updates to the 2023 Standards of Care in Diabetes. There are about 16, but I want to highlight one in consideration of the social determinants of health in guiding the design and delivery of care. So I did mention the bus system, but there's also others. So recommendation 1.7 was added to address the use of community health workers to support the management of diabetes and cardiovascular risk factors, especially in underserved communities and healthcare systems. So you can give more information to patients regarding community and social service resources for additional help. And an example of this is the YMCA's diabetes prevention program. It does focus on basic lifestyle changes, such as modest weight loss, eating healthily, and regular physical activity. On the bright side, there are multiple YMCA locations in Maryland. It's important while leveraging your role to take into consideration health literacy and numeracy. So health literacy is defined as a degree to which individuals have the capacity to obtain, process, and understand basic health information. So, and health numeracy requires primary, applied, and interpretive numeric skills. So what does this mean? It means that I could say to a patient that your A1C is 10%. And if someone does not have the knowledge on what the A1C is or what numbers those goals should be, it might mean nothing. So it's important that you ensure patients easy to understand information and reduce unnecessary complexity in explanations. And so the average reading level of Americans is 6th grade. And so making sure that your handouts are about that level is helpful as well. So another example of this, instead of saying you have hyperglycemia, you could say you have high blood sugar levels. It's very simple, to the point, and it will help patients with effective communication. Maryland Primary Care Program resources. So on the Maryland Primary Care Program website, there are resources on the left side of the website, not the left side of the slide. And so for the Maryland resources, there's the Mid-Atlantic Business Group on Health Obesity resources. And this is a list of practice supports and patient resources on addressing obesity, including guides, videos, and communication. And there's also the behavioral health resources listed to help Marylanders find mental health and substance use disorder resources. I really like this one because stress can elevate your blood glucose levels. And so having someone to address that in a team-based setting would be helpful. There's a directory for diabetes prevention programs and contact information. There's a link to the Giant Nutrition, which offers free online phone consultation, online nutrition classes, workplace wellness webinars, community events, and podcasts to help Marylanders make the best decisions for their health and well-being. And then we also have Giant Pharmacy, and they offer medication synchronization through the Time My Meds medication synchronization program. So a case study. So tips for putting it all together. We want to identify existing resources and guides. You want to check your local hospitals, health departments, senior programs, recreation departments, and reputable organizations like the American Diabetes Association. You want to work with others to identify resources. So talk to other healthcare providers, talk to somebody else at another practice. What are they handing out? What are they doing? You want to identify resource options that are low or no cost. So patients may not be able to afford a diabetes class, but you can point them to the MDPCP website and see what they can flip through. You could redirect patients to reputable sources such as Medicare.gov, heart.org, CDC.gov, diabetes.org, or eatright.org. You can evaluate and update your resources regularly because these resources do change often. And as I said earlier, the standards of care guidelines update yearly. You can encourage confidence through self-monitoring, so a food diary or sending them that goal tracking template for blood sugars, giving hard copies or through the EMR. You can conduct phone calls or verbal or EMR messages for reminders for planned visits or phone follow-ups. And you could use your knowledge within your scope of practice. Kindly remember that the interpretation of labs, diagnosis, levels of physical activity recommendations are left to the clinician. But if a patient asks you why they should take this seriously, you now have been educated on this topic and the chronic complications of diabetes. So the patient is a 63-year-old female. She has a chief complaint of, I'm frustrated with conflicting information on the internet, and I'm tired of poking myself. Her last A1C was 9.4%, and that was in January of 2023. Let's say we're still in June. Medication compliance, she takes metformin as prescribed. Appointment compliance, she was no call, no show in March 2023 for last blood draw. Meter, she uses a glucose monitor with a test strip, and fear foot amputation. So in a situation like this, what would you tell the patient? Okay. So when we put everything together, I want to let you know, firstly, we should let the patient know that we're going to try our best to answer all questions and concerns to the best of our abilities. We want to redirect the patient to reputable sources such as eatright.org, diabetes.org, or the MDPCP website to avoid conflicting information. You can let the patient know that there are continuous glucose monitors that will track blood sugars that go in the arm, show up on her phone, and this way she doesn't have to prick herself. You can let her know the A1C recommendation is to be drawn every 3 months, and that you notice she missed the March appointment and we're currently in June. So it's really important that she schedules a follow-up and to reschedule if she ever misses a date again closer to the date than waiting 3 months. And then you know that a decrease in A1C can result in a decrease in long-term complications. So you can also let the patient know that. And for her feet concerns, you could recommend that the patient doesn't walk barefoot, doesn't clip her own toenails, and also recommend compliance for her podiatry or foot doctor appointments. As always, remember your scope of practice. It's better to say you don't know something and that you'll pass it on to the MD on behalf of the patient than to give misinformation that may cause harm or cause you to lose your license or certification. So let's try these again. I believe this time you could just put them in the chat again, numbers 1, 2, and 3, and we'll see if we changed our answers. Unfortunately, I can't see the chat right now. Okay, I see 11% false, true, 11.3% true, true. Okay, 11.3% false, true. Okay. Yeah. Okay, I'll wait for maybe like 2 or 3 more responses because I want to leave time for a Q&A as well. 11.3% false, true. So yes, that is correct. The percentage of population that has diabetes in the US is 11.3%. For rapid acting insulin, it works after 15 minutes. So number 2 is false. And the YMCA does have a diabetes prevention program. So it is true and it is national, but I did highlight Maryland. So these are my references. Oh, I don't want to click on anything. And thank you so much for your time. Are there any questions? And you can scan this as well, and I will get back to you within 48 to 72 hours with my answer. But if there are any questions right now, I'm more than happy to take them. You could put them in the chat, but as I mentioned, I'm not able to see the chat as much as I'd like. Okay, I will wait another minute for questions, and if not, we can get into prediabetes. I didn't really touch on it heavily, but we could talk about it. I'll give you guys until 12:10. If there are any questions. Oh, thank you. Thank you very much. So if there are any questions, I'll wait another 15, 30 seconds. Okay, so it's officially 12:10. I'm going to talk a little bit about prediabetes, just because we didn't touch on it as much. So as I mentioned before, it is reversible, and it is classified by the A1C of 5.7 to 6.4. I do want to take a pause. In case there are questions in the chat, I truly apologize. I cannot see the chat fully. So I'm just going to talk about the prediabetes, okay? So it's going to be classified by an A1C of 5.7 to 6.4. So the goal of most physicians when they refer patients to me as a dietitian is to manage the prediabetes, and they want the A1C to be less than 5.6% or at least trending down. So what I mean by trending down is if they come to me and their A1C is 6.3, if they come back to me in 1 to 3 months and their A1C is 5.9, it's at least going in the right direction, which is towards normalcy. So the goal is for the patient to no longer have prediabetes, and we don't want it to progress to diabetes. So what do I do in a situation like this? I work with the patients for changes in eating habits, lifestyle changes, such as identifying stressors in their lives, and bored eating or emotional eating. And most times we try to do a weight loss goal of 5 to 10% of body weight. And if you weigh 200 pounds, for example, 5% weight loss is 10 pounds. We have found 5 to 10% weight loss can decrease this risk or A1C marker by 0.5 point on average. You are ready? Okay, no problem. Well, I will see you guys in the motivational interviewing section.
Sorry to cut you off, Kimberly, but
that's okay.
Thank you. If anyone has any questions for Kimberly, please, I hope you scanned the barcode. If not, just send your questions to us and we'll direct them to her. Thank you. And we'll see you in the main room for our last topic of the day, motivational interviewing.
Thank you. Okay.
Hi, everyone. Just wanted to say if you click the blue Leave Room button, and then there will be a prompt to click Leave Breakout Room, and that will bring you back to the main room.
Kimberly, on to you.
Hello, everyone. I'm happy to be here today. Today, I'll be covering the topic of motivational interviewing. So a little bit about me. I'm an alumna of the coordinated program in dietetics at Howard University. I'm an inaugural member of the STEM Scholars Program at Howard University, and this program's aim is to increase minorities who are getting terminal degrees, MD, PhDs, or PhDs. I'm a registered and licensed dietitian in Indiana. My clinical specialties include acute inpatient services, critical care, and general outpatient services. Also an incoming at the University of California, Davis. So the content outline today I'll be covering the presentation objectives, definition, the spirit of motivational interviewing, the 4 principles or processes of motivational interviewing, 4 skills of motivational interviewing, putting it all together, closing remarks, references, and some time for questions and answers. Presentation objectives. At the end of this presentation, participants will be able to understand the principles of motivational interviewing, understand how you can use motivational interviewing in your day-to-day role, learn how to apply motivational interviewing techniques to improve patient outcomes. So if you could kindly take 15 to 20 seconds to answer these polls, I would greatly appreciate it. Okay, so I see some answers coming in. Okay, so we're at about 20% completion. Okay, so I'm gonna close this poll for the sake of time. Thank you. I'm gonna share the results. Okay. And so I will not answer or share the correct answers yet because we're going to do it again at the end, but that's okay. Thank you. So from henceforth, I'll be referring to motivational interviewing as MI in most cases. So some of you may be wondering, what is MI? So the definition of MI is best described as a style of counseling that inspires neutral or reluctant clients to change. In the outpatient nutrition world, we refer to patients as clients. In simpler terms, it is a specific approach that optimizes the individual's drive for change. MI techniques have been around since 1991, and with limited time here, I'm going to emphasize the most important overarching themes and skills. So the spirit of motivational interviewing. So have you ever encountered a patient that was resistant to change? Imagine a patient saying, I know I need to get my blood pressure down. I don't want to have a stroke like my dad, but I just love my fast food. The spirit of motivational interviewing, or MI, involves partnership or collaboration, acceptance or autonomy, compassion, and evocation. So for acceptance or autonomy is when a practitioner also supports the client during their current state instead of attempting to exert control and make the client take action. And evocation is aiding the client in voicing ideas about the change. I wanted to highlight those two because their definitions don't necessarily match how they sound. So collaboration or partnership is we're going to work together to get your blood pressure down when responding to a patient. Autonomy or acceptance is I'm excited to hear about your favorite fast food options. Thanks for reminding me that we need to do this in a way that will work for you. Compassion, I am sorry that happened to your dad. And evocation, can you help me review what is important to you right now? In a situation like this, you may learn that stopping at the fast food restaurant serves as the only reprieve the client has between work and home, or that the large fries helps the client relax. However, we wouldn't have gotten to this point peacefully and without defensiveness if we didn't take the MI approach as a healthcare professional. The 4 principles or processes of motivational interviewing. So the 4 principles or processes of motivational interviewing are engage, focus, evoke, and plan. So for engage, when engaging clients provide warm, friendly greeting, this focuses on building rapport or a trustworthy relationship with the client. So this is an example of focus. To focus means you can invite the client to consider a specific topic. For example, the RD will say, given your recent diagnosis of diabetes, is there a specific change you've already thought about making? The client will say, no, it's all very overwhelming and I don't even know where to start. So the RD would say, would you be interested in hearing some changes that other clients of mine with diabetes have made? Client would say, yes, that might be helpful. And the RD would say, some like to take a look at meal planning options to keep their blood sugars consistent. Others like to learn about carbohydrate counting, which might also help. Which of these topics, if any, would you like to focus on today? Evoke. Clients may not be ready to make a change right away. Therefore, it's important to take time to find out more about their thoughts and feelings about change. Find out why they want to make the change and have them voice the benefits that are more important to them. I will discuss how to do this in the next few slides. Plan. Once clients seem to be committed to attempting a behavior change, guide them in developing a plan for implementation that works with their lifestyle. It's important that the client leads this process. How do you think you'll go about making that change? Is a great question to ask. And when the goal setting process is client-led, clients will feel empowered to follow through. Core skills of motivational interviewing. So the core skills of MI are open-ended questions, affirmations, reflections, and summaries, also known as ORs, as well as desire, ability, reasons, need, commitment, activation, taking steps, also known as darn cat. Open-ended questions. To encourage the client to share all information that may be helpful, open-ended questions are preferred over closed-ending questions. The practitioner uses these questions to find out more about their client's experiences, while at the same time introspecting strategic, evoking questions throughout the session so clients can express why making the changes might be beneficial. A closed-ending question such as, do you want to make this change, would only elicit an answer that's yes or no. But an open-ended question such as, how would making this change make your life better, invites the client to respond with specific reasons for how making the change would be beneficial. So some of you might be familiar with a very frequently used open-ended question that we use in the outpatient world is, what brought you here today? So what long-term consequences of diabetes concerns you most is another example. And a close-ended question would be giving advice hidden, which would weaken the question and it would stop the change in momentum and it might make the client reluctant to continue the session. So would you be willing to walk at lunchtime? If the client never brought up walking, or at lunchtime, that's giving an advice, and that wouldn't work out in all cases or in most cases. And so the goal is to have at least 50% of your questions during that session be open-ended. So how to practice? You want to practice with a partner, you want to collect some of your favorite open-ended questions, and you want to go back to the drawing board if you receive feedback. So affirmations. In MI, it's important to listen for expressions of clients' character strengths and mention these throughout the session. Examples of affirmation include you're very committed to raising a healthy family, or thank you for coming in today. I know it was not your idea to see me and I appreciate it. This one fits when you know the client is reluctant, and affirmations made intermittently throughout the sessions support the client practitioner relationship and enhances client confidence in behavior change. So how to practice this? You want to look for an effort or strength. You want to form the affirmation and you want to practice saying it out loud. Reflections or reflective listening. Reflections are paraphrases of what the client is saying that often go beyond mirroring their words to reflect underlying meaning. For example, if a client says, I like walking, but I don't like doing it alone and it's time consuming, you might say, so if I understand you so far, you know that walking is beneficial and you like walking with others and haven't found a way to fit it into your schedule. In this reflection, the RD or practitioner takes a guess at some of the feelings that the client is experiencing, and there are many ways to reflect. This is just one. So some reflections are very short and similar to what the client says, while others might be lengthier or more complex, and they might take a guess at an underlying meaning to try to get the client to speak more about it or evoke. So examples of mirroring words are what I hear you saying is, or so you feel, let me see if I heard you correctly. How to practice this, a general rule of thumb is to provide 2 reflections for every question you ask the client, but you do want to be mindful of inflection, which is your tone of voice. You don't want to come off sarcastic or non-interested, and you want to also keep reflections short if possible. Summaries. So summaries are extended reflections offered now and then throughout the session to piece together different statements that the client has made. So in a few sentences, the summary of the key pieces of the session so far, and doing so demonstrates active listening while allowing the transitions to new topics as needed. So for example, let's see if I heard you correctly or right, Mrs. Jones, XYZ. Have I missed anything? How to practice this? You want to form a summary and you want to practice summarizing a typical session that you may have depending on your specialty and role, and you want to say your summary out loud. Okay. So darn cat. Darn cat refers to listening for keywords that indicate change. This helps us transition the change talk, which is another skill of MI that we're going to get into shortly. So these were desire statements about preferences to change. So I want to, I would like to, I wish. A is for ability statements about capability. I could, I can, I might be able to. R is for specific arguments for change or reasons. I would probably feel better if. I need to have more energy to play with my kids. Need statements about feeling obliged to change. I ought to, I have to, I really should. Commitment statements about the willingness to change. I'm going to, I promise, I intend to. Actuation statements about their willingness to change. I am ready to, I will start tomorrow. And taking steps, statements about action taken. I actually went out or this week I started. So how to practice this in your sessions, you want to actively listen for those key phrases I mentioned that give insight on how the client feels about change. So change talk. So clients may say many things during a session, everything from why they came in to the appointment, to how they feel about their lifestyle, to things that don't have anything to do with your session. But the most important statements are those that express an interest in making a change or making a behavior change, which is change talk. The more change talk the client says or speaks during the session, the more likely the client will be able to make that change or willing to make that change. And that's why change talk is such an important part of MI. But there are different kinds of talk. So there's change talk, which is where the client verbalizes desire, ability, reasons, need, commitment, and or action taken. I really see where this would be good for me, and I'm ready to take the steps to do it. But then there's also sustained talk, where the client verbalizes reasons for staying the course and not changing. This seems to be hard right now. I don't think I'm ready to give up my ... Then there's self-exploration talk. The client is verbalizing that they are contemplating or exploring issues around change. I think my doctor has a point. I would experience much more energy if I did this. And then lastly, there's resistant talk. So client verbalizes that they are not willing or able to make a change. Example of this is, I'm tired of people suggesting that I need to change. I'd rather die happy than eat that. So putting it all together, do you remember this statement from earlier? I know I need to get my blood pressure down. I don't want to have a stroke like my dad, but I just love my fast food. Here we could see some change talk as well as some sustained talk, right? So I know I need to get my blood sugar down is change talk. I don't want to get a stroke like my dad is change talk, but I just love my fast food is sustained talk. And remember, sustained talk is when the client verbalizes reasons for staying the course or not changing. Okay. And so to highlight change talk, you should provide responses that emphasize it with a reflection technique or an open-ended question. So these examples show reflection. You saw how difficult the stroke was for your dad and you don't want to follow in his footsteps. So that reflects change talk only. Or you like the taste of fast food, but you don't like what it does to your body. That reflects the sustained talk, but it follows by change talk from the practitioner's point of view, not the client's. So an open-ended example of using that skill is, how interested are you in making this change on a scale of 0 to 10, with 0 being not at all interested and 10 being very interested? And just to summarize, the change would be giving up fast food. Closing remarks. Okay. So in summary, by putting the clients in the driver's seat, the provider makes them feel respected, in charge, empowered, and free to make choices that best align with their goals or values and lifestyles. So how can this be applied to improve patient outcomes? You want to start with a positive encounter as soon as the patient walks in the office. Whoever they see first should be building rapport with that patient or a trustworthy relationship. Engagement is very important. It's one of the spirit of MIs. Eye contact, body language, client-centered small talk, reflection. And then on a more personal note, it's going to require you practicing and growing your own skills, whether in private, in your bedroom, talking to a teddy bear, or with like standardized patients or with a real patient. So how do you do this? You pick one of the skills that I reviewed and you experiment or practice. You review how it went and you go back to the drawing board. You pick the things that worked well and you work on the things that didn't work so well. And then you pick another skill and you rinse and repeat. So let's try these questions again. Let's see if we gained any knowledge or changed our answers, or if we kept the answers the same. Okay, so I see we have about 38%, 41% completion. I see the goal of others has been about 50%, so I'm okay with that. We can end it here. We're at 55%. Okay, and now we'll share the results with you all. And so, number one, which of the following words is not used to describe the spirit of MI and its expertise? Yes, good job. So the spirit of MI, as we remember, is collaboration, autonomy, compassion, and evocation. And then clinicians may advise, inform, or even warn, but ultimately it is the patient who decides what to do. That is 100% true. And then the ORs stand for openness. No, because OR stands for together. So it's open-ended questions, affirmations, reflections, or reflective listenings, and summaries. And so, yeah, we're gonna stop sharing the poll. These are my references. And thank you for your time. Are there any questions? I'm happy to answer. We have about 9 minutes, or I could talk about how you can elicit change But feel free to scan this QR code. It will take you to a Google form where you can ask me your question. If in case you don't want to put it in the chat or you can't think of one right now, and I will respond within 48 to 72 hours. Okay, I'm going to give one more minute for questions, and if not, we can continue our session. We can talk about when it's time to give advice. We could use the elicit, provide, elicit model, which is the EPE, which is another part of motivational interviewing. Kindly, if there are any collaborators that can see the chat, are there any questions before I move forward? Because I cannot see the chat.
Great question, Kimberly. There are no questions right now that are in the chat.
Okay, no problem. Okay, so we could talk about the elicit, provide, elicit strategy. That is another part of MI. MI is so rich, y'all. Like, it's really great, but there are so many components. And so I really tried to give you the meat and bones. And right now I'm going to give you like a nice side dish. So for the elicit, provide, elicit, or EPE, you want to state the facts and leave out the word you, because you don't want anyone to feel offended. And you want to also look for a desire for the client to change. So again, that change talk that we talked about. So initial eliciting questions would be, what do you know about the effect of carbohydrate containing foods on blood sugar? Another elicit question could be, what information do you need from me about this right now? And then providing that neutral information. Remember that P in the EPE means provide. So again, we're continuing with the diabetes trend. So providing the neutral information, an example of this is when people eat carbohydrate foods in these portions, their blood sugars are most apt to be in the normal range. Or this is the amount of pasta that provides 15 grams of carbohydrates. It is a third cup. So as you can see, it's very neutral. I'm not saying you need to eat a third cup or you need to do this. I'm just laying out the facts of how 15 grams of carbohydrates affects the blood sugar. And then the last E in the EPE, elicit, provide, elicit, is also elicit. So eliciting responses, it's a very to the point question is, what is your response to this information? Or what do you think of this chart? Or what are your thoughts about all this? This way you're getting your patient or client to respond to you, but it's still an open-ended question. So they're going to say what they do understand, what they don't understand, or how they feel about it. And this is also a good way to integrate handouts with the EPE, because for that P, the providing part, you could also be showing like a model or a handout saying this is the amount in this, and you could just show it as well. So I have a handy sheet or a handout that has all these food items listed for the 1 carbohydrate count. Might this be useful to you? And then you could just show that to the patient. And whenever you can, it's really important, at least in my field, to link education materials or resources to specific things that the client has asked you for, because that counts as an intervention as well. Okay, well, that's all I have for you all today.
Wonderful. Thank you so much, Kimberly, for sharing your knowledge with us today, and a great session.
Thank you.
And I'll just reiterate, for those who may have questions for Kimberly, you can continue to drop them in the chat and we'll send them over. Okay, so that kind of brings us to the end here. So I'll just do some closing remarks and we can go ahead and close out our session. So I'll keep these remarks brief. I know everyone has stuck around for several hours and we've absorbed a lot of information here today, but I just wanted to say what an amazing set of sessions. I'll take a second here for a big round of applause to everyone here today, including our speakers, the team behind the scenes, and all of our attendees. The 2023 Staff Training Academy would not be possible without all of you here today. So as you reflect on today's event, we kindly ask that you fill out the post-test. Kelsey will drop a link to the post-test in the chat right now. You will also find it on the Google site. You can scan the QR code that goes out with that as well. It should only take a couple minutes, but if now's not the time, the PMO will distribute it through all our regular communication channels, so you'll have the opportunity to complete it later. We will accept responses for the post-test until close of business on July 10th. In terms of next steps, the recording and slide deck from today's event will be made available on the Google site, and the PMO team will distribute links to both of these through all our regular communication channels as well. We will also make it available on the MDPCP Educational Sessions webpage. In the meantime, let us know if you have any questions as we process that in a slide deck and recording. And lastly, we hope that you found today's Staff Training Academy valuable. As you process all the information from each session, we hope you take a minute to see how it connects back to the 3 core concepts of the MDPCP learning system: strategic goal alignment, all teach, all learn, and support and sustainability. We want to make sure we tailor the learning system offerings to be beneficial for you all, whether it's a future training event, webinar, resource guide, or something else. So as always, we accept all feedback. We love to hear it. We love to read it. Feel free to send us an email, reach out to your practice coach, or engage with us in any other format that we've mentioned. Again, thank you so much for joining us today. Have a great rest of your day and a great long weekend ahead.